Check sound. Check. Check. Check sound. Check. Check. Check sound. Check. 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 Check sound. Check.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh.
Shalom, Namo Buddhaya.
Salam kebajikan.
Salam sejahtera bagi kita semua.
Good morning to all of the professors, doctor, and all of the audiences. I am Adinda and my friend Budi on behalf of Anesthesia Department. First, we would like to welcome you today to our department to continue BCCM or Bali Combined Clinical Meeting. We're so delighted to have very special speaker, Dr. Anuraju, Dr. Kim, Dr. Satrio for today's event here in Anesthesia Department.
So to Prof. Cokorda Gede Agung Senapati, spesialis anestesi konsultan anestesi regional, Dr. Ida Bagus Krisna Jaya Sutawan, spesialis anestesi konsultan neuroanestesi, Dr. Cahya, Dr. Sindri. To begin with, we will welcome Profesor Dr. Made Wiryana, spesialis anestesi terapi intensif, subspesialis terapi intensif konsultan, subspesialis anestesi obstetri konsultan, to share a few words. To Prof. Wir, time and place is yours.
Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya. Salam sejahtera bagi kita semua. Selamat pagi to all my friend, Dr. Kim, Dr. Nuraju. Once again, welcome in Bali. Welcome again in our department and study program. And also my friend from Semarang, Dr. Satrio. You are many time coming to our department for that. So this morning we will have a lecture. I don't know what that like that from the expert from the Adelaide, Dr. Kim and Dr. Anuraju. You know, everybody you have known Dr. Anuraju and Dr. Kim also. The photograph of Dr. Anuraju over there, and maybe someday Dr. Kim also. Dr. Anuraju and Dr. Kim, you have to know that nowadays we have a lot of registrars, 142 registrars, and I don't know, maybe medical student, 20 or 30 every cycle, about 6 weeks in our department, that we call the STASA. After in the six semester. After that, we round in our department like that for that. So nowadays we have a big opportunity for us because the expert will be give us a lot of experience, lot of knowledge that we are sharing for us this morning. You know that we still facing about the mortality and morbidity of the mother and child. So that's why after our registrar, after 6th semester, after they are coming to a chief registrar, we send them to the, especially all the rural area, especially in East Indonesia, about 2 months at a time around for that, especially our programs about mother and child. But we don't know, nowadays the phenomena will change. We are facing about obesity now. We don't know why. Maybe because of the Kentucky Fried Chicken or McDonald's like that. We don't know about that. So that's the development of the disease, and we are facing for that. So that's why we have to express our knowledge for the new patient, the new problem in our department. So we will continue our study program to Kupang. We hope that maybe next year or next 2 years, because we still need a lot of anesthesiologists for that. So adik-adik semua biar tahu beliau-beliau ini sudah lama bersama-sama kita. A long time, about 10 years we are together with Dr. Kim and Dr. Anuraju. We are together in this class for that. So we hope that for today you have a lot of question, a lot of discussion for the expert. We hope that you will have a lot of knowledge or experience if you are passing or the graduate for the to be anesthesiologist, especially if you are in the rural area like that. Sekali lagi, selamat mengikuti acara ini. Once again, thank you Dr. Anu and Dr. Kim. So for the next, please convey my best wishes to Prof. Vigos, Prof. Rosli, Prof. Taslam, Sam, and also missingly, I congratulations. She had a baby, I think. Okay, yeah. So sekali lagi, selamat mengikuti acara ini, acara yang begitu baik menurut saya. Tidak dibatasi waktu, kita bisa menanyakan apa saja kepada beliau. So before we are closing, I want on behalf of the department and study program, we would like once again thanks very much to Kim and Anu and also Dr. Satria, and thanks to Dr. Sindri, Prof. Jo, Dr. Cahaya and Dr. Bagus Krishna to organize this meeting. Thank you once again. Saya tutup dengan Parama Santi. Om Santi 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 Om. Wassalamualaikum warahmatullahi wabarakatuh. Shalom Namo Buddhaya. Silakan.
So today we'll be having a lot of topics about anesthesiology, especially in obese patient. The first one is about physiological changes in obstetric patient.
And the second one, a management of obese patient with opioid-free anesthesia.
The next one is anesthesia in patient with obesity.
The next one, we have airway assessment in obese patient.
And last but not least, the updates in obstetric anesthesia.
Without any further ado, we'll welcome Dr. Marilaita Sindriani as the moderator. To Dr. Cindy, the time and place is yours. Please show her CV. As we can see, Dr. Sindri was born in Jakarta, 13 May, which is tomorrow, 1984. Okay. Okay, to Dr. Sindri.
Not yet. You're making me shorten. Okay, thank you for the announcement, Adinda and Dr. Budi. Welcome and good morning, especially to our distinguished speakers and also to Dr. Cahya, Dr. Gus Krishna, Prof. Wir. Thank you for the openings. And it's a very pleasant that we could have this scientific meeting that could be made in a very short notice. Shout out to you all, the residents, registrars and all that you have made this possible. To make this short, I will ask for Dr. Kim Osborne. He will present a physiology changes in obstetric patient. From the IT team, would you please give us pointers or something and make sure that the slides would play? Do you have Dr. Kim's resume? Okay. Dr. Kim Osborne from the Adelaide team was born. Okay. Is a member of ANSCA, RCOG, FIRCS from University of Adelaide, and now act as Australian Institute of Company Directors. So many affiliations and obviously a very well expert. To Dr. Kim Osborne, it's your turn. Thank you.
Okay, thanks very much. It's a pleasure to come and talk to you today, and I've really enjoyed the meeting, and particularly some of the singing last night was excellent. Okay. So as I said, we're talking about the physiology associated with the obese pregnant patient. And just to hold on.
The the slides, please.
Or just
Okay. Okay. Can you
okay.
please?
So this is just the topics that I'm going to cover during the talk. I have a few slides on the anesthesia specific, but I'll try to flick over those because they're going to be covered later on this morning. Oop. So just to clarify what we're talking about with regards to the definitions, that the WHO have got, the WHO have got the normal, overweight, obese, and then they classify them into the class 1, 2, 3. Now I understand that in Indonesia you've got a slightly different classification, but I apologise, I haven't got that classification up here. And then in addition, elsewhere there are additional classifications of class 1 into the morbidly obese, super obese, and the super obese. Now fortunately I don't think you have many of those super obese and super obese. I've just been to America and I did see lots of super obese and super obese, but I wasn't giving any anesthesia, so I was very relieved. Now, just to reiterate, we covered some of this yesterday, but the maternal effects and why it's important for us. But also, we need to be cognizant and aware of what the implications are also for the neonate. So, there's a high risk of maternal death, and that's associated with thromboembolism. There's also an increased rate of preeclampsia and hypertension. Gestational diabetes and type 2 diabetes is more common, and that has implications for anaesthetists, for example, with larger babies. Obstructive sleep apnea, and as you can imagine, postpartum hemorrhage is more likely. I mean, they're more difficult at caesarean section. That's more difficult for the surgeon, the obstetricians to perform. There could be tears, and also there's an increased rate of caesarean section. If you think about with the obese patients, the wound is more likely to be infected under the pannus. It gets hot and sweaty, and then if we think about we're giving prophylactic antibiotics, they need to actually get from the blood to the skin, so the distance they have to travel is increased. And as I said, increased rate of induction of labour and failure of induction of labour. And then in the neonate, increased rate of stillbirths, miscarriage, preterm labour, fetal distress, macrosomia, low APGAR scores. So I've just got the little, I think that's freely available, the article from the World. So I looked up and saw what's happening in Indonesia, and there's actually been a longitudinal study looking at the rates of obesity over time, and this is actually is done by. The study was done by some New Zealanders from the medical school in Otago, and it was done they had 5 different waves of collecting data, and they collected on 42,000 patients. And just this is a bit of the methodology, just that they did, and obviously when they're longitudinally following patients, some of them fall out of the study, and then some of them are lost to follow-up. And so that's just explaining how they actually did the collecting the data. Now, if we look at this, why is this important for us? So this is each of the waves of the study, the 5 time periods, and then we've got the types of patients and what's happening to their weight. So probably what we're interested in is this group here. And we can see that that's trending upwards. And unfortunately, also, as people in Indonesia get older, they do tend to get a bit more, they put on a bit more weight. But not this group. The 70-year-olds have sort of remained more similar. Now, this is another way of looking at the data. So they've actually then gone, okay, let's look at 2040. That's the most common figure. And what's happening is that, and this is the distribution of the body mass along here. And what we can see is that these are mean figures, the average figures. So the mean has gone from about 20, and now it's crept up to 25. But also, there's the curve. Before it was very up and down. Now it's stretching out. So we're getting more people in this area here. Fortunately, not many in the greater than 40 BMI, which is good. And then there was they used the data to actually look at younger groups in more detail. And so if we look at because what we want to see is who are going to be the pregnant patients in the future. We don't want to look just now, what's it going to be in the future. So if this group here, the children aged 6 to 14, the percentage that are overweight has gone from 2,000 to 5%, it's gone up to over 15%. So that's a bit of a worry, because we need to think of as a public health issue. And but as anaesthetists, however, we have to look at what's going to happen in the future. So that's why this session's been really useful, I think. Now, I managed to look up the World Atlas on Obesity, which has got data on over 200 countries, and looking at what's actually happening. So there's a section on Indonesia, and this is published in March. They produce it every year. They release it on World Obesity Day. So there's actually a World Obesity Day on the 4th of March. So they reckon the annual increase so it's increasing at a rate of almost 6% in Indonesia. And the childhood in obesity is increasing. So these are predicted levels that it's actually going up at a rate of 9.1%. And in the women, it's increasing, and the girls. So that's a bit of a way. So we need to be prepared for it. So next bit will go on to the effects on the heart and the cardiovascular system. So believe it or not, there's actually a formula that's been established to calculate the circulating blood volume in obesity. Now, I hope that's not an exam question, because I'd fail, because I'm not very good at remembering, but there is actually a formula of how to calculate what the blood volume is. But that assumes the circulating blood volume is 70 mils per kilogram. So there was a recent study using starch dilution, and they calculated during this study, but that was only in 30 patients, that when the BMI 27, this was a study done I think in America, that the blood volume mils per kilogram was 95, but when you're bigger, your blood volume per kilogram is lower. So it doesn't. So we just have to work out BMI, weight, etc. in calculating or estimating what the blood volume is. Now that's important if you've got a PPH. And where I come from in Australia, I always say to the registrars, beware the smaller Asian women. You know, they won't have a blood volume like a 80 kilogram patient. Someone who's 45 kilograms, you know, they've lost 2 litres. Well, that's really significant. So, but just to be aware, there are changes with BMI. And so, just recently, there was a study or review looking at how to actually use this, and they were suggesting that it varied. This is how, so in the fit severely, in healthy weight, 95. And as I said, it's important because you can then use this to guesstimate what the blood loss is in the volume in relation to what the percentage of the blood volume lost. And they produced a table that I sort of made it up as a table. I don't know if that's going to be practical in a bleeding patient, but it's a useful way to sort of just remind everyone that it does vary. So, other cardiovascular effects. So the actual cardiac output does increase for every mils per minute for every 100 grams of fat. So the cardiac output does increase. And that puts an additional, as well, there's an additional volume load to the heart, and that can cause left ventricular hypertrophy. And with the increased heart rate in pregnancy, that'll put a load, or decrease the diastolic interval, and which therefore means that relaxing period of the heart, when coronary artery blood flow occurs, that'll be decreased. So that if you've got the left ventricular hypertrophy and this decreased myocardial perfusion time, there's a possibility of getting damaged myocardial diastolic relaxation of the heart, which could then lead to increase in cardiac failure. So that's in a severe situation. Also, with the deposition of adipose tissue around the conducting system, there's a risk of conduction defects and also contractility. Now, the other thing is we always, Arnie will talk about it in the simulations about avoiding aortocaval compression. But if you think about a woman with a big penis and obese abdomen here, that'll produce additional aortocaval compression. So it's important, you know, if you're doing it in one of these super obese patients, just remembering the risk of increased aortocaval compression, which will cause decreased venous return, then bradycardias and hypotension. So how about the respiratory system? Just to remind you of inspiratory volume, inspiratory reserve volume, tidal volume, expiratory reserve volume, functional residual capacity, and I've just got another slide of that. It's got coloured and a bit of cartoons on it. So just remembering your basic physiology. But what actually then happens in the obese patients And what happens is this area here is adversely affected. So there's reduced airway diameter can occur in some of the areas of the lungs. So if we also talk about that closing capacity, where the lungs will collapse and not get as much aeration of those areas of the lungs. So this is the lungs are pulled open, and then with expiration they decrease, and then further small airways can decrease, and so you'll have areas where the lungs will collapse. So if we go on to the next slide, we can see the tidal volume being up here. The obese, when they're awake, this is the closing volume here, so they're getting in that closing volume area. And then when we give them an anaesthetic, put them off to sleep, and that's anaesthetised, it gets even worse. So there's more likelihood of getting hypoxia associated with the obese pregnant patient lying down, and then also giving them an anaesthetic. So just going over, this is a list we talked about reduced functional residual capacity, closing volumes. Also, if you've got the weight of the abdomen, the weight of the chest wall and the breasts, that'll decrease the compliance of the chest wall, and also the abdomen will also, in additional, if they then, when they're doing the caesarean section and they've got the wound and they're pushing up, that'll further decrease the capacity, the compliance of the lungs. There's also an increased risk of sleep apnea and increased risk of difficult intubation, and there's also hypoventilation syndrome can occur in some, but these would have to be the super obese. Now, in relation to the sleep apnea, why does sleep apnea occur? Well, there'll be increased edema of the of the upper airway. However, and hyperemia. However, when patients are pregnant, there is a change and there's an increased sensitivity. So is a decreased risk related to being pregnant. So as you know, what's the average arterial CO2? It's about 34, 35, because there's a relative respiratory alkalosis with the increased respiratory minute volume associated with pregnancy. The other thing is that when patients are pregnant, they don't tend to lie on their back, they lie on their side, which makes breathing easier. So just talk about, so I think I've mentioned some of those issues, and fortunately with progesterone, that does decrease airway resistance. So when patients are pregnant, they've also got the increased size of the uterus, the placenta, and the baby. So 20-25% of the cardiac output is going to the uterus and the placenta. So there's increased oxygen demand. So at a caesarean section, there's increased oxygen demand and take up, but we've also talked about the effects on the respiratory system. So there's increased risk of hypoxia or desaturation. So those are the other things that we've sort of mentioned. And I know there's another talk about anesthesia per se, so I won't steal the thunder of the next speaker. Just going over upper airway, that's already in pregnancy, it's hyperemic. But then if you've got increased adipose tissue, that'll be greater with the tongues, the lips, the nasal passages, mouth opening. And then in the obese patient, there's the size of the neck, and so that can affect if you do need to ventilate and also actually intubate. And that can also, if you do get in the can't intubate, can't ventilate, front of neck access is associated with the physiology. I just like, I know this will go through before in the next talk, but just sort of reminding everyone again and again about positioning, because that, with an obese patient, if you lie them on the bed, even if you've got tilt on, they often, anyway, they find it a bit hard to breathe when they're awake. So anyway, just putting a little bit of head up tilt will make them feel more comfortable, will improve their ventilation while you're pre-oxygenating them. But then there's also the issue about optimising position for ventilation. So in pregnancy, there's increased risk of aspiration associated with decreased gastric emptying and reflux. So that is made worse when patients are obese. There's also this condition called fatty liver, which is very rare, but that is also increased in patients who are obese. So what happens with the renal system? So there's increased angiotensin converting enzyme and increased renin levels. The glomerular filtration rate can decrease, and there can also be sodium retention in these obese pregnant women. Endocrine, a lot of the talks yesterday were talking about gestational diabetes and an increased risk of type 2 diabetes or worsening of it. And so there's peripheral insulin resistance, and the lipid levels also increase. Hematologically, we know that pregnancy is a hypercoagulable state, and then with the associated immobility, often in the more obese patients, there's an increased risk of thromboembolic disease, the need for thromboprophylaxis. There can be, in the really more obese patients, there can be an increase in the hematocrit, and there's also decreased immune defence, which increases the risk of infection. And as I've said, if at caesarean section, following caesarean section, the wound is much more likely to be infected, unfortunately. So how about just remembering about the pharmacology? So what do you use? Do you use lean body weight? Do you use ideal body weight? Do you actually use the body weight of the patients in these obese patients? So the suggestions are to use total body weight if you're using dexamethasone, then using lean body weight when you're calculating the dose of thiopentone and propofol and opioids, and then using ideal body weight for non-depolarizing drugs, paracetamol, non-steroidal or anti-inflammatory drugs. So if you were to use non-steroidals, just keep them at the ideal body weight. And as I've mentioned it before, but I just want to emphasise a bit about antibiotics. I mean, I don't know what you use for prophylaxis for wound infections, but we use cefazolin, 2 grams, and then our protocols are that if they're over 120 kilograms, we increase the dose to 3, because we do not want these patients to have an infection. And it's related to, if you think about the little cells, the capillaries, where the antibiotics are, but they have to get to the skin and the adipose tissue, or the skin surface, the skin, to actually work to prevent the infection. So having a higher level in the blood is a good idea. So there've been some studies that actually recommend that. There've been some studies that suggest additional antibiotics, but that's for the infectious diseases people in your hospital to recommend, but also to consider that increased weight and the increased dose. So, as I've mentioned, in the more obese patient, they're not as mobile. The anatomy, adipose tissue, can make venous access more difficult. Blood pressure monitoring. If you've got really large arms, fitting the blood pressure cuff on, it just won't fit, and it comes off. And in the middle of the case, it's really difficult because you want to know what the blood pressure is, and you've got a bleeding patient, you don't know what the blood pressure is. So we had a case in our hospital where there was a patient with about 180 kilograms. They didn't put an arterial line in, and one of the learnings of it was actually, because then she actually had placenta accreta, which was unknown. So, because the scanning of these patients is difficult. So one of the learnings was have a lower incidence of likelihood of putting in an arterial line. And obviously epidurals and spinals can be difficult. So hopefully you don't have any of those patients. So this particular, it's an old case presentation, and it's actually from New Zealand. So they have a lot of islanders. So, and they're very big. So this was an islander. And what they'd done is they'd actually used tape to pull the adipose tissue out to the side. The other thing I just want to emphasise is that one of the physiological effects of these patients is where do you put the spinal? Where's the level? Because you can't feel the iliac crest. You can't feel it. So anyway, but hopefully these patients are super obese. So hopefully at the moment you won't have those patients. And Anu yesterday was talking about using ultrasound to get the level. So that's one of the things. And I was really impressed that the access to the ultrasound. So just talking about this as a study looking at the depth of the epidural space with BMI. Yep. Oh, that's another. Just reminding that you want to get the level right, because you do not want to hit the conus or the spinal cord with your spinal needle, and that's just some of the effects of that occurring, and that we're not great anyway at determining what the levels are. Okay, so I won't steal your thunder about the so that's just in summary. What I've gone through is the definitions, the implications, the trends, including in Indonesia, and the cardiovascular, the respiratory, GI, renal, hematological, the musculoskeletal effects, and remembering also the pharmacology. It's important to remember not just the physiology but also the pharmacology that alters in these obese pregnant women. So, do we have questions now or at the end? At the end. Yeah. Okay. Thank you very much.
Thank you very much, Dr. Kim Osborne. I think we have to change mic. This is for the...
Ooh, okay. It's okay.
As a quick reminder, actually we have displayed this in the YouTube of Bali Anesthesia. If somehow you have to go and then you still want to look and want to hear about this scientific meeting, you can Google and then look inside the YouTube of Bali Anesthesia. This is a live scientific meeting. And actually, I've seen some chats and questions, but I will summarize first, and then after 3 speakers, and then we will start the discussion. We go next. The second presenter is my favorite doctor since I was still in the first year as the registrars. He's so handsome today with some suit, of course, the brown suit. It's like a polo shirt model, I guess. To Dr. Cahya Aryasa. Please step forward. He'll bring us about the management of obese patient with opiate-free anesthesia. Could it be possibly done? To Dr. Cahya, the time is about 20 minutes, please.
Thank you, Dr.
Okay,
Sindri.
thank you.
Thank you, Dr. Sindri, for Dr. Anu and Kim. I'm sorry, not speak with English. I'm speak with Bahasa. Easy to me. Sorry. Slide. Saya akan sharing sedikit tentang penggunaan opiat di anestesi atau di dunia lah dulu ya. Jadi opiat free itu suatu paradigma baru, ya. Jadi kapan digunakan? Kenapa kita menggunakan opiat pada saat pemberian anestesi? Kemudian kenapa mulai agak dikurangin atau lebih diselektif penggunaannya? Nanti saya jelaskan di slide ini, ya. Jadi opiat free itu sebenarnya suatu paradigma baru. Dia mulai muncul ketika krisis opiat. Artinya ketika kita memberikan opiat untuk menekan nociceptive atau nyeri pada pasien yang dilakukan operasi, tapi timbul efek bandul, efek serangan balik ke kita, pasien menjadi ketergantungan, ditambah lagi persepan yang agak lama sehingga dia mudah menjadi ketergantungan. Ternyata di anestesi, beberapa teman mungkin tidak tahu, ada dokter muda mungkin kurang paham. Untuk menekan rasa nyeri, kita bisa gunakan obat selain opiat. Itu konsepnya dulu, ya. Nanti diskusinya sedikit tentang opiat, suatu paradigma, opiat krisis, kemudian bagaimana kondisi ketergantungan obat di Indonesia, untung rugi penggunaan opiat, kemudian obesitas dan opiat sudah sedikit dijelaskan sama Dr. Kim. Kemudian nanti opiat free-nya, atau karena seorang anestesis cuman bukan hanya memikirkan ibu, dia harus juga memikirkan janinnya. Bagaimana sih obat anestesi yang akan kita berikan efeknya ke janin, ya. Opiat free itu suatu paradigma shift, sudah saya jelaskan. Saya langsung saja saya lanjutkan. Kemudian kenapa terjadi opiat krisis, ya. Jadi data di Amerika mengatakan bahwa 80% penggunaan opiat itu di Amerika. Jadi mengagetkan. Kemudian satu dekade dia meningkat menjadi 4 kali lipat. Walaupun Amerika itu 4, sekian persen penduduk dunia, tapi full penggunaannya lebih banyak di sana. Opiat krisis itu munculnya di sana, ya. Nah, saya ulangin dulu, saya jelaskan sebelumnya. Kalau kita menggunakan opiat, efek sampingnya mualan muntah, sedasi, irius, konfusi, delirium, dan beberapa lagi yang lain. Tetapi hipoksia, ilius, dan konfusi atau delirium itu ditampilkan di beberapa jurnal. Dia signifikan menyebabkan suatu morbiditas. Apalagi nanti topik kita hari ini obes pasien. Nah, opiat free sudah saya jelaskan tadi. Kita menggunakan obat selain opiat. Obat yang kita gunakan beberapa kombinasi. Kita menggunakan hipnosis, gabapentoid, NMDA, lokal anestesi, dan NSAID maupun alpha 2 agonis. Jadi itu adalah beberapa obat yang bisa digunakan untuk pengganti penggunaan opiat tersebut. Ini contoh suatu formula yang ditulis oleh Sinjin Brooks ya. Jadi dia mengkombinasikan dex, ketamin, lidokain, kemudian post-opnya paracetamol, NSAID, infiltrasi lokal anestesi, maupun kombinasi dex yang tadi bisa dilanjutkan dengan dosis lebih diturunkan. Itu kombinasi. Kalau saya tidak menggunakan ini, cuman kita lihat prinsip anestesi itu lihat pasiennya juga. Ya, monitoring, close monitoring duranto op itu prinsip anestesi. Jadi setiap pasien respon pemberian obat itu beda. Ya, ini contoh yang sudah sering dipublish. Kemudian seperti saya jelaskan sebelumnya, bagaimana sih kondisi penggunaan opiat di Indonesia? Kita bisa lihat di grafik ini, dari 2009 penggunaan opiat, kemudian kasus narkotikanya juga naik. Kemudian barang bukti aset itu hampir 1 triliun, angkanya banyak, 1 triliun. Barang bukti aja 1 triliun, berarti penggunaan narkotika di Indonesia itu sebenarnya tinggi, tapi tidak terlihat nyata di permukaan. Kemudian bagaimana kasus adiksi, ya, adiksi di Indonesia ketergantungan obat itu. Karena kita tahu Indonesia apalagi Bali itu daerah populer ya, jadi banyak kunjungan wisata. Kemudian dikatakan juga tingkat penjualan narkotika itu cukup tinggi. Dari 273 juta penduduk, 6 juta itu terlibat dan ketergantungan obat-obat. Ada yang lebih parah lagi, anak-anak sekitar 87 juta anak-anak itu sekitar 5,9 juta itu anak-anak sudah terlibat, dan 1.600.000-nya pengedar. Itu bahaya. Mudah-mudahan tidak ada yang terlibat di sini ya. Saya harap tidak ada yang terlibat di sini. Jadi tinggi sekali, itu suatu hal yang sangat menyedihkan. Berita yang terakhir, BNN mengingatkan 50 orang meninggal setiap hari karena narkotika. Jadi ini salah satu usaha-usaha menekan efek dari penggunaan opiat itu. Jadi terlalu liberal, jadi mulai dikurangi. Nah, seorang anestesi tugasnya apa? Seorang anestesi bisa juga menyebabkan pasien itu jatuh dalam penggunaan opiat yang lama, karena misalnya kita berikan dosis obat peresepan untuk di rumah yang panjang, cara menyimpannya salah, sudah tidak diminum, tidak perlu, tapi disimpan, kemudian diambil oleh anaknya, diambil oleh ponakannya. Itu salah satu yang dikatakan di jurnal bisa menyebabkan penyalahgunaan narkotikanya meningkat. Jadi anestesi juga berperan, tapi apa yang kita bisa lakukan? Garis-garis merah ini kita bisa lakukan bahwa peran anestesi penting untuk menurunkan opiat krisis ini. Ya, jadi seorang anestesi harus melakukan pada preoperatif mengedukasi, kemudian memberikan ekspektasi, memberikan informasi tentang efek samping penggunaan opiat, kemudian mengidentifikasi apakah ini pasiennya berisiko untuk jatuh dalam keadaan ketergantungan opiat. Kemudian intraoperatif harus menggunakan multimodal, regional, kateter kontinu seperti epidural atau epidural continuous yang biasa kita sudah lakukan di sini. Salah satu tujuannya adalah menurunkan dosis opiat post-op-nya. Kemudian post-operatif multimodal sudah pasti, regional continue, penggunaan adjuvan dan lain sebagainya. Jadi itu adalah peran anestesi yang dapat menekan terjadinya lebih parahnya opiat krisis di dunia ini. Apa untung dan apa ruginya ya? Jadi kalau kita menggunakan opiat dan tidak menggunakan opiat, jadi walaupun opiat free gitu misalnya, tetap kita harus waspada karena kita menggunakan beberapa multimodal obat bisa menyebabkan bradikardi ketika kita berikan dexmedetomidine, kemudian gangguan hepar, jika kita menggunakan acetaminophen, ini adalah beberapa risiko penggunaan opiat free. Tapi kalau untungnya banyak, seperti yang Dr. Kim jelaskan, no respiration distress, terutama obes. Ya, post op kalau kita tidak menggunakan opiat, tidak ada gangguan respirasi, karena Dr. Kim sudah menjelaskan bahwa respirasi pada pasien obes morbid, apalagi post opnya lebih berbahaya. Next slide. Nah, ini adalah beberapa obat yang bisa kita pilih, kita gunakan dengan dosisnya. Saya percepat. Nah, kalau dibandingkan penggunaan opiat dan opiat free, bagaimana? Kalau ada pertanyaan seperti itu, ini sebuah jurnal yang menampilkan bahwa kalau kita membandingkan OVA atau opiat based anesthesia, dari segi analgesia opiat free tidak lebih rendah, sama, ya, dia tidak lebih inferior. Kemudian dari pain score juga, kebutuhan opiat pasca operasi OVA itu tidak lebih inferior, tetapi dia lebih untung di PONV post op, tidak ada lebih rendah kejadiannya pada opiat free. Kemudian length of stay, lama di rumah sakit, dikatakan sama pakai opiat maupun tidak menggunakan opiat. Sebuah meta-analisa yang lain yang cukup panjang membandingkan opiat dengan opiat free, lebih unggul OVA dalam hal PONV, tidak menurunkan kualitas nyeri. Kemudian sarannya dari meta-analisa ini adalah penggunaan opiat itu harus case by case. Kita lihat apakah pasien ini akan berisiko ketergantungan atau penyalahgunaan opiat untuk selanjutnya. Nah, bagaimana dengan kejadian di cesarean section, di seksio, di obstetric anesthesi? Ternyata memang kecil, 1 dari 300 ibu hamil itu kalau dia akan bisa jatuh dalam keadaan opiat krisis atau penyalahgunaan atau ketergantungan, 1 dari 300. Jadi kejadiannya itu dipengaruhi oleh lama pemberian. Makin lama Anda memberikan opiat pasca operasi, dia akan lebih risiko ketergantungan di cesarean section. Jadi seksio juga bermasalah, ya, artinya bisa juga pasien itu akan jatuh ke dalam keadaan ketergantungan. Nah, kita bisa lihat di sini seksio cesarean itu merupakan urutan ke-7 jatuh dalam keadaan penyalahgunaan opiat atau ketergantungan. Ya, yang pertama total knee arthroplasty, cesarean section itu nomor 7. Jadi tetap walaupun seksio yang kita lakukan 1 hari 2 hari langsung pulang, kejadian untuk jatuh dalam keadaan ketergantungan opiat itu memiliki nomor 7 dari jenis operasi yang lain. Nah, karena topik kita obesitas, jadi kapan bagusnya digunakan opiat free? Jadi Dr. Kim sudah menjelaskan opiat free secara general ini spesifik populasinya adalah lingkaran ini, tetapi karena kita bahas obesitas, jadi bagus sekali untuk obesitas, bagus sekali untuk obstetrik pasien dengan sleep apnea. Cancer juga bagus, colorectal erasmus baru bagus, chronic pain syndrome bagus, pasien dengan opiat addiction juga bagus. Misalnya seorang yang operasi di luar kasus obstetrik, dia sedang menterapi dirinya untuk lepas dari ketergantungan, kemudian perlu operasi, seorang anestesi akan berpikir kalau kasih opiat dia balik lagi, ya kan? Kalau tidak pakai opiat mungkin belum ngerti ilmunya, jadi bisa sebenarnya kita menggunakan opiat free anestesi. Dr. Kim sudah menjelaskan obstetrik, obesitas in obstetrik itu masalah global, ya, bukan masalah kita saja semua. Jadi komplikasinya makin tinggi. Seksio kalau obesitas tadi sudah lihat fotonya, kalau dia seksio spinalnya akan luar biasa. Walaupun pakai ultrasound saya pernah coba, susah juga. Jadi itu tantangannya banyak sekali di anestesi. Ya, banyak sekali tantangannya. Semua ini sudah saya jelaskan sini, ada airway, monitor posisi. Dr. Kim sudah menjelaskan yang tadi. Saya lewatkan saja. Nah, ini adalah kondisi atau diagram bagaimana sih seorang ibu hamil yang obes, yang dijelaskan tadi secara fisiologi, terjadi peningkatan 20 sampai 30 cc, ya. Kemudian makin besar 30 minggu ke atas, volume plasmanya sudah makin meningkat, ditambah dengan obes, dia akan jatuh dalam jatuh ke left ventricle failure, jadi ventricle kirinya akan gagal jantung kiri. Tapi ditambah lagi yang berat lagi, kalau dia obes plus chronic hipertensi, kemudian ada sleep apnea, ada penyakit arteri coronary disease, lebih murah gagal jantung atau cor pulmonale. Jadi risiko meninggal tinggi sekali kalau pasien itu obes terus pregnancy. Ini salah satu diagramnya yang menjelaskan tersebut. Nah, obesitas post-op-nya sering bermasalah. Jadi respiration event itu meningkat, diikuti dengan makin tingginya berat badan, kemudian diikuti dengan penggunaan dosis opiat. Jadi dia akan, kalau dia makin berat, terus dosis obat opiat makin banyak, risiko respirasi pasca operasinya lebih tinggi. Apa yang harus kita lakukan sebagai seorang anestesi pada saat akhir operasi, ya, di ruang pemulihan, apa yang harus kita lakukan atau syarat-syarat bagaimana sih seorang ibu hamil yang obes harus kita lakukan ekstubasinya. Jadi karena resiko kegagalan respirasinya tinggi, jadi ekstubasinya harus benar-benar weak, ya, benar-benar sadar, bisa mengikuti perintah yang sederhana. Kita bisa gunakan topnya harus bagus, bisa mengangkat tangan atau mengangkat leher sementara, bisa berbicara atau mengikuti perintah sederhana. Jadi harus benar-benar weak, ya, tidal volume dan respiration rate harus bagus, berikan oksigen, close monitor di ruang pacu. Posisi tadi Dr. Kim sudah menjelaskan, repeat posisi, jadi tidak bisa sama dengan posisi pasien ibu hamil yang non obes. Nah, ini bagaimana dengan breastfeeding? Ya, bagaimana dengan breastfeeding? Tadi opiat free itu kan banyak sekali obatnya. Jadi seorang anestesi itu harus, ini adalah beberapa obat yang compatible yang bisa digunakan. Kemudian ada beberapa yang dikatakan non compatible, tetapi perlu perhatian jika ibu hamil itu diberikan opiat kemudian menyusui, harus close monitoring. Jadi dari resume dari ASA, sarannya adalah seorang anestesi itu tidak boleh mengganggu kemampuan ibu untuk menyusui, ya, tidak boleh mengganggu kesadarannya pada saat menyusui. Kemudian usahakan regional anestesi. Kemudian penggunaan opiat harus hati-hati, harus perlu perhatian. Siap. Ini 5 menit. Ini adalah summary, ya. Jadi bagaimana sih suatu obat itu bisa melewati atau yang boleh, ya, yang boleh diberikan. Jadi dia relatif dosnya, ini yang paling sering digunakan, relatif dosnya harus kurang dari 10%, milk plasma rasionya harus kurang 1, plasma protein bindingnya harus tinggi, lebih dari 90%, poor oral availability, waktu paruh, metabolit, dan tentunya ada sertifikat dari pediatrik. Jadi harus ada izinnya dari sana. Ini adalah beberapa obat, kita bisa lihat di sini, walaupun ketamin kita gunakan, tapi lihat juga, saya lewatkan slide. Ini perhitungannya, kemudian di sini, ini kan diazepam tidak boleh ya, klonidin tidak boleh, ketamin, tetapi ketamin ini masih pro kontra. Karena ketamin yang kita gunakan di prinsip di opiat base itu tidak dosis 3-5 mg per kilo, kita gunakan dos ultra low dose, jadi 0,125 paling maksimal 0,5 per kilogram berat badan. Jadi efeknya tidak sama jika kita gunakan dengan dosis yang klasik yang 3-5 mg per kilo itu ya. Jadi karena ketamin itu half life-nya rendah, kemudian rapid distribution-nya pendek 4 menit dan oral bioavailability-nya jelek ya, dia dinyatakan aman untuk digunakan pada ibu hamil. Kemudian ada beberapa analgetik yang compatible, yang centang-centang ini compatible, yang tidak ini perhatikan ya. Tramadol termasuk di sana, petidin, kodein, hati-hati. Jadi beberapa yang harus kita perhatikan jika kita menggunakan obat-obat untuk proses menyusui pada ibu hamil. Nah, ini bagaimana dengan penggunaan DEX? Jadi ini sebuah jurnal yang membandingkan penggunaan DEX dengan dosis 0,4, 0,6, 0,2 dan placebo. Dosis DEX yang digunakan disarankan adalah sekitar 0,4 sampai 0,6 mikro. Jadi hemodinamik bisa ditekan pada ibu hamil yang dilakukan general anesthesia. Itu hasil perhitungannya. Kemudian karena opiat free anesthesia itu suatu general anestesi, jadi proses monitor pada saat operasi harus ketat. Kita menggunakan Kikon dan Kino ya. Jadi harus digunakan monitor yang ketat. Jadi tidak bisa tanpa monitor. Kemudian bagaimana tentang ERAS? ERAS itu sudah booming berapa tahun terakhir ini ya, seksio ERAS begitu ya. Jadi di ERAS itu sudah sebenarnya dijelaskan bahwa penggunaan opiat dibatasin, gunakan adjuvan, usahakan regional untuk menekan opiat krisis. Jadi ERAS sudah menyatakan ada arah untuk menggunakan mengurangi penggunaan opiat. Slide. Sedikit tentang ketamin, bukan hanya sebuah NMDA saja, kita bisa lihat kita gunakan ketamin di OVA itu bisa hipnosis, bisa psikotomimetis ya, analgetik dan antidepresan. Jadi dosis yang digunakan bukan dosis yang klasik, saya ulangin lagi, dosis yang besar 3-5 itu kita gunakan low dose. Jadi nanti kalau ditanya apakah dia hanya sekedar MD, tidak, dia sebenarnya bisa antidepresan, analgesia, hipnosis dan banyak lagi fungsi yang sering kita tidak ketahui. Nah, yang terakhir, apakah opiat free itu intraoperatif itu bisa? Jawabannya bisa. Seleksi pasiennya, kemudian benar-benar dia indikasi, misalnya obes begitu, dia merupakan indikasi, disarankan opiat free bagus untuk pasien dengan obesitas. Ini beberapa kesimpulan saya karena waktu sudah habis. Saya kira itu yang bisa saya sharing, mudah-mudahan ada manfaat.
Terima kasih banyak Dr. Cahya, thank you very much. Yeah, actually we have the video Dr. Cahya himself doing the opiate-free anesthesia, but we save those for later after the discussion. We are going to the next presenter. It's a friend of Dr. Cahya, and he's my duet partner last night. So I hope we rock last night, I don't know. And afterwards, he's going out for some singing again with Dr. Putupram, I believe. So we really hope that now he did not lose his voice because of last night. Okay, but so let me present you Dr. Satrio. And he will present about the anesthesia with patient with obesity. He comes from Semarang, so it would be delightful to have him here. For Dr. Satrio, silakan. Give a big applause.
Yeah, thank you, moderator, Mr. Kim, Mr. Raju, Mr. Raj. To honor Dr. Chaya, I will use Indonesian.
No problem.
Again, maybe kita mulai ya. Kalau saya kita sambil belajar aja bareng-bareng ya, adik-adik. Karena kebetulan apa yang akan saya sampaikan sebenarnya hampir sama semua. We have the same. Oke, kita anestesi pada ibu hamil dengan obesitas. Ya. Ya. Seperti tadi Dr. Kim bicarakan, ini udah jadi masalah, ya, masalah luas di dunia di mana prevalensinya terus naik ya. Di mana ini obesitas ini berhubungan dengan outcome yang jelek, kurang baik dari ibu maupun anak, dari bayinya, ya. Seperti yang tadi hampir sama dengan Dr. Kim kayaknya, sepertinya tabel saya itu di mana itu akan berhubungan dengan komplikasi pada ibu maupun anak seperti diabetes gestasional, hipertensi gestasional sampai ke preeklamsi, ya. Kemudian adanya resiko perdarahan postpartum dan lain-lain itu pada ibu, ya. Sedangkan pada neonatal paling sering itu adalah makrosom, kemudian preterm delivery, kemudian juga adanya kematian janin. Hal itu kenapa kita perlu hati-hati untuk melakukan anestesi pada ibu hamil dengan obesitas. Ya. Ini seperti Mr. Kim tadi ya. Jadi kita sama menggunakan dari WHO, Mr. Kim, ya, untuk saat ini karena kita belum mengukur sendiri, kita nggak pernah melakukan penelitian sendiri, ya. Dimana setelah paling gampang ingatnya di atas 40, gitu. Di atas 40 kita bilang itu obesitas, ya. Terus di atas 40, 50, 60 tadi morbiditas, morbid obes, super tadi yang dibilang. Ya. Oke. Nah, ini bahan pertimbangan kita sebagai anestesi, ya. Nanti ada yang pengen saya sampaikan sih. Sebenarnya hampir semuanya hampir sama. Dan kebetulan jurnal yang jadi rujukan yang diberikan kemarin menurut saya hampir sama semua pasti. Cuma nanti ada beberapa hal yang mungkin akan sedikit saya khususkan karena itu akan menarik buat adik-adik sekalian. Ya, ini bagaimana kita melakukan assessment preoperatif, ya. Seperti yang Mr. Kim dari RW, ya. Resiko jelas, ya. Kalau yang udah residen pasti kita semua deg-degan, apalagi kemarin ada presentasi kasus, menurut saya bagus sekali presentasi, bukan bagus presentasinya ya, kasusnya sangat bagus walaupun hasilnya menurut saya tidak kita inginkan bersama, ya. Pada RW jelas kita akan berhadapan dengan kesulitan intubasi, pengelolaan jalan nafas yang sulit, ya. Jadi yang perlu kita perhitungkan apa? Ini kita sama-sama belajar malam patinya bagaimana, jarak tiopentalnya bagaimana, gitu ya. Kemudian respirasi, peningkatan osa seperti yang Mr. Kim bilang tadi. Kemudian bagaimana kardiovaskulernya, peningkatan resiko penyakit kardiovaskuler, hipertensi ini paling sering nih terjadi sama ibu hamil, ya. Dan kardiomiopati. Kalau yang mengikuti kasus kemarin, ketemu lagi kita di sini, ya. Itu dia kenapa kemarin sempat dijelaskan Dokter Cahya. Kemudian pertimbangan kita lainnya adalah faktor gastrointestinal, itu resiko aspirasi. Jadi itu yang perlu kita pikirkan, resiko aspirasinya. Kemudian metaboliknya, ya. Metaboliknya ini akan berhubungan dengan kapan sih dia kita puasain, ya enggak. Kalau kita puasain dia turun gulanya bagaimana. Nah, makanya kenapa sebenarnya ada eras itu, ya, ada eras, dia tetap puasa, dia tetap kita kasih carbo loading. Nah, ini sih yang mau saya tekankan, ini yang sering kita lupa sebenarnya, ya. Pada wanita-wanita yang dengan morbid obes, kita harus sering melakukan konsultasi, ya, terutama pada trimester 3 terakhir, itu paling sering yang harus. Nah, itu yang paling sulit kita lakukan. Kenapa? Pertama, pasiennya datang juga nggak jelas, ya, kadang bisa juga datang udah sito, ya, kemudian tahu-tahu udah di meja operasi. Hal-hal itulah yang biasa kita temui di lapangan, ya. Padahal dari pertemuan itu tadi akan kita lihat nih apa aja nih yang akan komorbid yang akan muncul berhubungan dengan obesitasnya. Kemudian fisikalnya kamu bisa lihat RW-nya bagaimana. Wah, ini kok kayaknya lidahnya gede banget ya, kok jarak tiopentalnya pendek banget ya. Nah, terus bagaimana kardiovaskular sistemnya? Ini bakal kita temuin di saat pertemuan terakhir itu sebenarnya, ya. Dan di situ kita juga bisa lihat punggungnya. Nah, kalau lihat punggungnya, maka kejadian seperti yang tadi mungkin kita udah bisa perkirakan, wah ini sulit nih, kita harus siap USG. Walaupun seperti Dokter Cahya bilang sulit, belum tentu juga pasti bisa. Yang kedua, nanti sambil ini, nah ini yang saya pengen ajak kita berdiskusi bareng, ya. Kita di saat diskusi, ya, sebenarnya saya pengen tanya, apa sih yang adik-adik omongin kalau kita inform consent pasien? Inform consent pasien. Saya pengen tahu inform consentnya boleh nggak? Dokter Sindril, saya mau salah satu residen kalau inform consent pasien morbid obes gitu. Nah, gimana sih inform consentnya? Tunjuk aja. Saya nggak suka cowok ya, jangan cari cewek aja, kita cari cewek aja, yang cewek. Oke, boleh. Kadang kata-kata kita itu perlu untuk kita menemukan kata-kata yang bagus di sini, ya. Pasien morbid obes, lehernya pendek, besar, sininya penuh. Misal kita ngomong, Bu, nanti operasinya sulit banget loh, resikonya begini, ada sampai mungkin kalau nggak bisa saya tusuk dari belakang, saya spinal, tapi itu juga belum tentu berhasil. Gimana kamu? Oh ya, silakan. Ya, silakan. Oke, boleh. Nggak, ini kita sama-sama belajar aja. Jadi bagaimana kita bisa mengungkapkan, ngomong ke pasien, karena resikonya besar sekali loh, ya. Pasien ini resiko besar sekali, seperti apa yang terjadi sama kasus kemarin. Kalau ngikuti ikut laporan kasusnya, pasien itu akan terus dia beresiko sampai yang seperti Mr. Kim bilang, post operasi juga kita perlu perhatian. Ya, silakan.
Om Swastiastu, selamat pagi dokter. Assalamualaikum, terima kasih atas kesempatan yang diberikan. Mohon izin dok, apabila memang dengan pasien morbid obes, tentunya karena awalnya memang kita rencanakan mau regional dulu misalkan, kita pasti akan inform consent, kita berikan penjelasan mengenai teknik spinal yang akan kita lakukan. Pertama itu, kemudian untuk risiko dan komplikasinya juga kami jelaskan. Nah, namun karena ada risiko kemungkinan gagal, tentu juga harus kami jelaskan juga untuk mengenai pembiusan umumnya. Nah, di sini mungkin umumnya kami akan menjelaskan dokter kepada pasien bahwa ada risiko untuk terjadi kegagalan pada saat pemasangan atau sekali pasang, dan juga risiko komplikasinya pun meningkat dok, karena pada pasien-pasien dengan morbid obes tentunya untuk manipulasi RW-nya akan lebih butuh yang advance, dan juga untuk risiko gagal tinggi, risiko komplikasi lebih meningkat, dan juga apabila terjadi kegagalan dan sampai misalkan pasien itu tidak dapat di manajemen dengan baik, mungkin bisa masuk ke perawatan intensif ataupun kematian.
Ini kan teorinya ya, ngomong ke ibunya misalnya, gimana cara ngomong ke ibunya, Bu, nanti kalau ibu gagal saya spinal, saya ganti intubasi gitu ya. Terus kalau saya gagal intubasi, ibu saya apain?
Dokter, mungkin umumnya kami tentu akan mengatakan kepada pasien apabila belum berhasil, kemungkinan akan kami lakukan bagging dan operasi paling berat bisa dibatalkan, atau istilahnya untuk pada saat itu kita bangunkan dulu dok, misalkan kepepet sekali.
SS itu batalin.
Oh SS itu dokter, mau nggak mau harus dilakukan dokter, paling mau nggak mau harus menyampaikan bahwa paling berat kematian dok.
Ya, kita sama belajar. Emang ini sulit ya, kita akan ngomong suatu hal yang sulit, tapi yang menarik dari jurnal ini tadi yang saya pakai adalah di sini kita bisa menjelaskan, ya kita bisa menjelaskan kita bakal melakukan begini nih dengan keadaan ibu nih, ya kita melakukan ini dengan keadaan ibu, ya dengan keadaan ibu yang memang keadaan ibu kurang baik, ya kan. Nah, tujuannya satu, kita melakukan perubahan ini, misal ya paling gampang harusnya orang dengan supine, ya. Tapi karena ibu ini ada dengan dengan obes, ya maka kita posisinya beda dengan yang lain, ya dengan rem position misalnya, kita rem position. Nah, tujuannya apa? Ini adalah tujuan semua yang kita lakukan bertujuan untuk safety patientnya. Itu aja yang coba disampaikan ke pasiennya. Memang sulit, apalagi ngomong ke pasiennya ya, apalagi dengan risiko-risiko yang besar pada pasien morbid obes ini. Ya, itu yang saya menarik dari apa yang sama jurnal ini.
Terima kasih dokter.
Ya, terima kasih. Ya. Nah, terus kemudian ya, pasien dengan morbid obes ini ya, morbid obes ini dia harus di tempat yang baik ya, pengelolaan yang lengkap. Memang itu dia kenapa di tempat kita di Indonesia ini perlu adanya sistem rujukan. Tidak bisa dikerjakan di rumah sakit C, wah ini morbid obes ya, jangan kau paksa dikerjain di sana, mati konyol nanti ya. Ini buat teman-teman residen yang mau lulus. Jadi kamu harus, wah ini jatahnya dokter Cahya, harus saya kirim ke Sanglah nih gitu ya, jatahnya dokter Cahya gitu. Jangan kamu kerjain sendiri misalnya kamu di tempat daerah ya, karena kenapa di sana kamu bakal sendirian, tapi di sini akan banyak staf yang bagus-bagus yang bisa mengerjakan, membantu dokter Cahya misalnya seperti itu ya. Nah, dan yang paling penting persiapan ya, tata persiapannya bagaimana, jelas RW, difficult RW, equipmentnya, alat-alat intubasi sulitnya harus siap untuk nemenin ya. Kemudian kalau memang perlu ada di daerah, di rumah sakitnya ultrasound pakai ya, dan monitor yang komplit ya, mau yang non invasif maupun yang invasif ya. Semua pasien morbid obes sebaiknya ya dijaga dengan rem position dan left uterine display. Diangkat sedikit pantatnya ya, pantat kanan atau pantat kiri yang diangkat, yang agak di displacement. Ayo, tujuannya apa sih? Ayo sama-sama ini kita, tujuannya apa? Ini ada soal OC loh, itu ada dokter Alit dia kalau ada sindroma tujuannya itu ya untuk yang rem position ya, untuk memperbaiki posisi pandangan, dan sedangkan kalau left uterine replacementnya untuk memperbaiki preloadnya nantinya. Nah, ini seperti sama ya. Sebenarnya tujuannya adalah, kalau bisa dilihat, adalah bagaimana membuat ini sejajar. Jadi sehingga pandangan akan lebih baik. Itu tujuannya rem positionnya. Nah, ya. Seperti kita tahu ya, jelas kita semua kalau berhadapan dengan kasus ini pasti akan melakukan neuroaxial block, ya kan? Spinal lah pilihan paling ini, paling sering. Nah, pada pasien-pasien dengan BMI lebih dari 50, kita butuh dosis yang lebih kecil. Itu dia kenapa saya kadang tadi with Mr. Kim said if patient with 120 kilograms, yeah, we need increase for the prophylaxis. Is it written on label of the? Nah, that's it. Itu yang mau saya. Pada keadaan obes, apa yang kita lakukan kadang sedikit off label. Baik tadi misalnya bila Dr. Kim bilang dinaikkan, di-increase itunya, antibiotiknya untuk profilaksis. Tapi pada obat bufinya sedikit turunkan. Dan itu tidak ada penjelasannya, ya kan? Tidak ada penjelasan dalam label obatnya, ya. Ya, untuk misalnya penggunaan kateter tidak ada masalah karena bisa digunakan bila operasi yang memanjang biasa ini. Ini seperti yang dokter bilang ya, bagaimana pentingnya positioning preoksigenasi, kemudian staf yang bagus, bagaimana persiapan intubasi sulitnya. Ya. Kadang juga penggunaan CPAP dan pressure support ventilasi itu pada pasien obes tapi non hamil itu baik, jadi bisa digunakan. Ya. Untuk general, ini sekarang seksi cesarean delivery pada general. Jelas problem yang paling sering dan kita takutin adalah masalah RW, ya. Tuh, bisa di situ malah dalam jurnal kalau kita menghadapi itu harus ada 2 anestesi, ya. Bisa saling bantu, nggak sendirian. Kamu tadi saya bilang kalau kamu di daerah terpencil sendirian, mending rujuk, ya, mending dirujuk karena kamu akan mengalami kesulitan tanpa teman, ya. Terus hati-hati sama dosisnya. Hati-hati sama dosisnya. Kenapa? Karena balik lagi, semua label obat itu sangat terbatas dan hampir nggak berbicara tentang kalau orang obes gimana sih. Kadang pengelolaan obes bisa berubah, tidak seperti hitungan berat badan biasa, ya. Nah, untuk postpartumnya hati-hati karena tadi seperti kita bahas kemarin untuk masalah yang pada pasat conference ya, dia akan meningkatkan risiko infeksi, tromboemboli, depresi nafas maupun macam-macam masalah kardiovaskuler lainnya, mungkin kardiomiopati, ya, yang masih mungkin terjadi sama pasien itu. Dan kita harus meminimalisasi bagaimana kejadian komplikasi postpartum itu terjadi. Gimana caranya? Post-op harus kesini dulu, ya. Post-op harus kesini dulu. Dan semua udah, kemarin aja udah masuk ICU, tapi ternyata misal udah balik ruangan pun masih bisa bermasalah gitu, ya. Jadi sangat hati-hati, ya. untuk analgetik jelas. Saya termasuk sepaham dengan Dokter Cahaya. Saya juga termasuk bukan pengguna opioid, tapi masih menggunakan untuk rescue. Ya, untuk rescue keadaan-keadaan tertentu di mana pasien masih sangat kesakitan, mau nggak mau kita pakai. Ya. Nah, tujuannya apa sebenarnya? Kalau kita memiliki analgesi yang adekuat, maka mobilisasinya semakin cepat. Mobilisasi yang cepat, maka resiko-resiko tadi DVT dan lain-lain bakal sangat berkurang, ya, bakal hilang. Ya. Ya. Ini adalah bagaimana maternal obes itu sekarang menjadi masalah, ya, karena outcome yang buruk buat ibu dan anak. Itu dia, saya sangat suka banget di sini, gila, multidisiplinnya sangat digunakan, ya, karena bertujuan sama, itu untuk kesuksesan pengelolaan pasiennya. Terakhir pesannya adalah careful planning will improve maternal and neonatal safety. Terima kasih. Terima kasih banyak.
Thank you very Terima kasih banyak, Dr. Satrio. Okay, now we move on to discussion session. There are several questions here. I'll try to summarize, but I'll prioritize those who are here, present today. Kepada audiens yang ingin bertanya, saya persilakan. Kalau misalnya merasa kurang nyaman berbahasa Inggris, nanti akan saya bantu jelaskan. Silakan, raise your hand if you have questions, and I'll try to direct it to the speakers. Which one? Ayo, ada yang mau bertanya? Oke, silakan, kasih mic-nya. Habis ini baru saya coba bantu baca dari YouTube. There's a live questions, and then we will continue to the YouTube questions.
Baik, selamat pagi, dokter. My name is Vanessa. I'm from Udayana University. So my question, there will be two questions for Dr. Osborne itself. I was curious about the pharmacology topics that you brought. So you said that each drug must be calculated with different body weight. It can be with total body weight, lean body weight, or ideal body weight. So I was curious, what is the consideration to calculate for each drugs, and maybe there are consideration from the pharmacokinetic itself, or maybe from other aspects. And then for Dr. Cahya, for the opioid-free anesthesia, is there any considerations from the fetus aspect, beside the social and from the maternal aspects that you have explained, to use the opioid-free anesthesia? Thank you.
Terima kasih, thank you. To Dr. Kim, she's asking about the drugs.
Yep.
Yep. In my response.
I mean, I think I think these are probably fairly generalised principles around the pharmacology and pharmacokinetics. I think particularly regarding the use of saxamethonium, it's far better to give a bigger dose than a smaller dose, because that's when you're going to get into trouble. But also and I'm fairly certain that the pharmacokinetics of the saxamethonium does relate to using the dose related to their weight. Whereas the others, I must confess I haven't looked into it in great detail, but I think those are basically the principles upon which to do it. Because it's very difficult to do some of those pharmacokinetic studies, particularly in the pregnant patients. So I think, and we always have this problem, what do you actually use? And but I think but the guidelines that I said are basic principles. But as the other speaker mentioned, there's no real clear guidance. And I was quoting one study, and then the other one was a review from the British Journal of Education in Anesthesia, which said, there's not a great deal of data. So I haven't really answered the question, but it's a difficult question to answer. But I think just basically think about what you don't want to do, and you don't want to underdose induction agents because you don't want a patient to be aware. But then also you don't want to overdose them, especially if you're using TIVA, so then extubate them and then they're still anaesthetised.
Just add with the because with succinylcholine they do the total body weight. It's because there is lots succinylcholine is metabolized by pseudocholinesterase, and the amount of pseudocholinesterase is weight based. So there's lots of pseudocholinesterase in the circulation. If the patient is 100 kilos, they might have, say, if it's 1 milligram per kilo, you get 1 milligram. If it's 200 kilos, they'll have 200 kilos. So that's why succinylcholine is based on that. Others, as Kim has mentioned, it can go anywhere. It depends on the pharmacokinetics and pharmacodynamics of the study.
Thank you. Menjawab kurang lebih? Ya, pelumpu otot. Hati-hati pelumpu otot, jadi itu yang baru terakumulasi sesuai berat badan. Kalau yang lain ya masih kontroversial. Dr. Cahya, Dr. Satrio mungkin ada tambahan? Pertanyaan Dr. Cahya ya? Ada tadi. Tentang opiat free ya?
Ya dokter, untuk yang opiate free anesthesia mungkin dari sisi fetusnya bagaimana?
Sisi janinnya gimana?
Iya,
Aman
terima
atau
kasih.
tidak?
Tadi kan seorang anestesi itu harus memperhatikan 2 orang sekaligus, ibunya dan bayinya. Jadi obat yang kita berikan ke ibu harus kita pikir juga efeknya ke bayi. Melalui apa? Melalui transfer placenta. Kedua, melalui air susu ibu nanti. Jadi tugas seorang anestesi sudah saya jelaskan tadi ada 6, tidak boleh menghalangi, tidak boleh mengurangi kemampuan, usahakan regional dan lain sebagainya, itu ada 6 dari rekomendasi ASA. Jadi opiat free untuk ibu hamil terhadap bayi pasti lebih bagus, cuman beberapa obat ada yang dikatakan masih pro kontra, contohnya ketamin. Ketamin kalau diberikan low dose, saya setuju memakai aliran low dose, tapi kalau dosis besar boleh, tapi bayi harus di close monitoring, harus di monitor dengan ketat karena menyebabkan sedikit sedasi dan menurunkan kemampuan menyusui, itu saja. Jadi opiat free untuk ibu hamil apalagi obes sangat menguntungkan. Terima kasih ya.
Terima kasih. Dr. Satrio mungkin ada tambahan, Dok? Oke. Ada pertanyaan yang terkait dengan materi Dr. Satrio. How's the anesthetic management of thromboembolism? Jadi gimana manajemen pasien hamil obes dengan thromboemboli? Kira-kira gimana, Dok?
Terima kasih. Kalau pasien dengan tromboemboli, kalau kita sudah mengalami, jelas yang kita lakukan adalah resusitasi ya. Resusitasi ABCD-nya harus langsung kita tangani untuk tromboemboli. Karena pada saat tromboemboli pasti tensi tiba-tiba turun, heart rate bisa langsung beradi atau malah langsung rest keadaannya. Jadi jelas yang harus dilakukan pada saat terjadi awal tindakan dari tromboemboli adalah resusitasi. Cuma, nah ini ada cumanya. Yang kita lakukan adalah pada pasien ibu hamil dengan obes, morbid obes. Maka tetap kita harus mempertimbangkan hal-hal tadi, ya. Bagaimana kita membuka jalan nafasnya dengan baik, dan kemudian bagaimana aliran ke preload tetap bagus. Jadi saran saya untuk melakukan resusitasi pada orang dengan tromboemboli ya dengan left uterine displacement. Jadi tetap dia harus dipinggirkan karena untuk membuka preloadnya dan bagaimana airway-nya tetap terjaga. Kalau memang itu segera intubasi kalau memang kita pasien tidak bisa kita jaga untuk jalan nafasnya. Demikian dok, terima kasih.
Terima kasih. For Dr. Kim, there's questions about what should we do if we have failed spinal 2 times in the same patient. Should we try to repeat the spinal attempt or proceed with general? And what should we do if our spinal needle could not reach the subarachnoid space because the skin and fat is too thick, just like your picture? Is there any tips and tricks?
I think whatever you do, it's a situation of what we call shared decision making with the patient. So you'd have to have, if you wanted to proceed with whatever you did, you'd have to have a discussion with the patient. And also it depends on if it's an emergency, if there are any time constraints. So the decision's about shared decision making, and also any time constraints with the obstetrician. So the other thing is, as you suggested before, if you can't reach the space or you're having difficulty, the ultrasound machine can be, if you're skilled at using it, can actually assist in determining which is the best space to go into, what the depth is, what the angulation is. So that's one thing. The other thing is, as mentioned before, using an epidural with a spinal is actually advantageous. With these obese patients, having to use a longer spinal needle, you put it in and it wobbles, or can wobble, and you don't know where it's going. But if you use a 2E needle, that's a lot tougher to help guide to find the space. Then putting the spinal needle through the epidural, most of the time, about 95%, you'll hit the CSF. Sometimes because the epidural space is this big, the intraspical space is smaller, so you sometimes miss it. So I think, the principles I think are around shared decision making, discussion about time pressure, using the ultrasound, and then also using a combined spinal epidural, using the epidural to get a feel of where you're going, and that's a definite endpoint. Well, that's an endpoint, and then putting the spinal in, getting some then giving the dose, then also putting in the epidural catheter, so you've got enough in there. Is that okay?
Dr. Anu, do you have something to add? How if we fail about 2 times? The spinal.
As Kim mentioned, it's all a decision, like, if the patient is happy to go ahead to have another spinal, definitely. It all depends on, like, you have a decision with the surgeon as well with regards to the time pressure, as Kim's mentioned. So if it's an emergency section, if the patient is, like, there's no way, like, there's no point in just continuing. It's a failed
Point of
course.
no return.
Yeah.
Let's go.
So in that case, you just go there.
One other thing, there are some quite rare conditions where local anaesthetic does not work. So they're rare, but just be wary that there's an anaesthetist at the Royal Adelaide. She's had about 4 spinals and they just don't work. So there are patients, and it's not. So just be cognizant of, sometimes there are patients that the spinal does. There's a condition called Ehlers-Danlos, and Ehlers-Danlos type 4, I think. There's a higher incidence of the local anaesthetic doesn't work as well.
Thank you.
If you're doing a CSC, like, if you have a difficult spinal, that's a high chance that the surgeon it's not a high chance, the surgeon's going to have difficulty with the surgery as well. All right, means that it's lots of fat.
Correct.
So as Kim's mentioned, you get a spinal, you use a 2V needle as an introducer and put a long spinal needle through it, and get the CSF and then put the local anesthetic in there. And the heat of don't remove the 2E needle, thread an epidural catheter in. So he said, I got a spinal, and we was trying for so long, we got a spinal in, and then we are happy, we'll pull everything out. Instead of pulling everything out, just thread the catheter in and fix the catheter to the back, because the spinal might wear off, and you can use that epidural catheter to top up.
Because often, because as Adu said, it's more difficult, they'll take longer. And the baby, especially if it's been in labour, they get in the angles of the uterus, so they may need to exteriorise the uterus, mean pull it out, and so that you need a better that can cause some pain sometimes. So that's where the CSE is really useful.
Okay. Actually, this correlates with the next question, just before break. Is there any difference between the high spinal in the obese and the non-obese? There's a question and you took that. Maybe Dr. Kim, Dr. Anuraju?
Okay.
Is there any difference, maybe from research or maybe some reports, case reports, the difference of high spinal in patient with obese and non-obese pregnant?
That's a good question. So how I think about it is you're putting the spinal in, and the epidural space has probably got more fat. So you may need a relatively lower dose because it does go higher. So how do you minimise that risk of it being high? And I tend to think testing it early to check, but also with the obese, I tend to put I'm more likely to put a bit of head up, just break the bed, so that it doesn't go as high, because we use hyperbaric bupivacaine, heavy bupivacaine, so we were able to manipulate it if necessary. So you've normally got your curvature of the thoracic spine anyway, but also in the obese, I do just put a little bit more head up, but I test it because quite often see if it actually is going up, and then if it is going up, then I'll put the head up. But also that if it goes high, it may mean the blood pressure may go low. So I've actually got my vasopressor going right from the beginning and having the blood pressure cycling regularly, so that we don't get dropping blood pressure with a high block. The other bit about managing a high block in the obese patient, or any patient, is the patients, if it comes up high, they lose their sensation of their chest wall, and that makes them feel anxious, and so they've got this sensation of shortness of breath. So what we tend to do is, and you probably do it already, get them to put their hand on their chest and get them to take a breath, and then they'll be able to feel their chest wall with their hand. They won't have the proprioception on their chest wall, but they could, and then reassuring them the saturation's okay. So that's one technique of, if it is a high block, managing we don't want to do that if they stop breathing, but if they're breathing normally, to reassure them.
Thank you. Dr. Satrio, mungkin ada yang mau ditambahkan?
Yeah, I agree. Patient with BMI more than 50 are likely to
Okay. Okay.
narrowing of the lumen.
Okay. So more than 50 lower intrathecal dose due to narrowing of the lumen. Okay.
It's always, can I just ask, it's always tricky, as we said, you put a lower dose of spinal, we don't know how much we put in. And if you have a BMI of 50, you know how long the surgery is going to take. Normally it takes you get a duration about a couple of hours. So that's why in these sort of situations, better do a combined spinal epidural. So you put a low dose in and then put a epidural catheter in. So you can always, you can say, even if that low dose is not working, you can always have the backup of that epidural catheter to top the patient up. So I think, Kim and my approach to these patients who have BMI 50 is to do a combined spinal epidural instead of doing a single short spinal, and do a low dose spinal and thread the epidural catheter in. I think your approach would be the same, right?
Yes, yeah.
Okay, Dr. Cahya? Enggak. Okay, we will have a break time for snack. Unfortunately, we have to bring them from outside to inside. Don't forget to get inside again because we have to watch the videos of the opiate-free anesthesia and also the videos of the awake fiber optic for the next session, Dr. Gus Krishna. So as a quick reminder, we can stand up and when we can have some snacks outside. Don't forget to come back again. We have about 10 minutes break. Please, please do remember to come back again and watch. We still have very interesting sessions right after this. Yeah.
She was that first one. He was really good. But both of them. Well, oh my goodness.
They asked about the Indonesian cowboy who is spinal. Indonesian cowboy we try 3, 2, second and third time.
Yep.
If
I forgot. Sometimes I end up going paramedia. You don't. Paramedia, not this one. Then I go paramedia. That's what I found.
The aim is just to get the access.
Oh, right, okay. Oh, you got your husband. That was good.
to all the audience. I really hope that you could come back to the classroom. We will start this scientific meeting again for the next session. Okay. It's a problem after snack. You have to call them up. Masuk yuk, masuk yuk. Masuk. Okay, we will start again. We are trying to relay the YouTube live again. Udah dicoba dulu. Kan mau putar videonya supaya. Udah live. Okay. 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 Because we have a very tight schedule today, I really hope they have the most and the highest experience. So that's why we are trying to keep this short. For the next session, we will play first the video. The first one is the opiate-free anesthesia, especially made by Cahya Aryasa. And the second one is the awake intubation using fiber optic, especially done by Dr. Ida Bagus Krishna. To the IT team, are you ready? Okay. We will play the video. Please enjoy. So this is the opiate-free anesthesia technique employed by Dr. Cahya. Maybe the sound, you could turn the volume. Yeah. It's already live? Okay, good. Okay, that's the first video, and now we will see the video of the awake fiber optic intubation. It's a very graceful method. Thanks to our supervisors, Dr. Cahya and Dr. Gus Krishna. Nicely done. Perfect. Give a big applause to Dr. Gus Krishna and Dr. Cahya. Very thorough and also very good video. Thank you to the IT team. Okay, we will continue with the next session. There will be two presenters for this session. The first one is Dr. Ida Bagus Krishna that would present the airway assessment in obese patients to Dr. Gus Krishna. Now it's your turn.
Thank you very much, Dr. Sindri, for the chance for me. I'm really happy today because I have a chance to stand here sharing with Dr. Anu, Dr. Kims, Dr. Satrio, Dr. Cahya, which is in my mind is always be a amazing anesthesiologist because from whom I learn a lot with anesthesiologists. Thank you very much. Welcome to Bali. Okay, today I will share a little bit about something simple. It's not happy things, right? It's just something simple, and I hope it's will be useful later on when we are practicing an anesthesiologist. Okay, first of all, we will talk about airway assessment in obese patient. It's just small thing, small part of anesthesia, small part, but well, it's quite important. Okay, so well, we just try to talk about it a little bit. Okay. Okay. Well, if you are guys, maybe this has already been said by Dr. Kim, Dr. Ano, Dr. Satrio. Everything is obesity is increasing. Well, we cannot avoid that. We cannot avoid that. They said that from 1975 up till 2016 is been triplet of it. Jadi sudah bertambah 3 kali lipat. Well, it's just time. So, what is that? What is to do with the anesthesiologist? What is to do with the anesthesiologist? Well, if an obese people increasing in number, that's mean a chance for we are anesthesiologists deal with this obese persons or obese patient in an operating room will be increased as well. So that's mean we have to know about these obese persons. Just now, Dr. Kim already talked a lot, and I'm really enjoying listening to your presentation about obesity, and thank you very much. So I will talk a little bit about this for the airway, okay? Just for the airway, okay? If we are talking about obesity and airway, what we're gonna say is, first of all, we have to know that there's a tissue. There's more tissue, right? A redundant tissue in upper airways, head and the neck area. We remember that. That's what always be in our mind. Okay, the upper airway, head, and neck area, there will be more redundant tissue, and then there will increase adipose tissue there, where in a pharynx, also in a hypopharynx. What does that mean? The airway will become narrower. Okay, we have a large tongue, large tonsils, and then there will be a deficit adipose tissue in the neck, shoulders. What does it mean? Will make hard for the person to move their heads. And all of that is really, really important when we are doing management of airway. Okay? Excessive tissue around the face, cheeks will make hard for us to do the ventilations. So all of these things is what we have to remember. Okay, so okay. Oh, no? Quite hard? Wow, it's too sensitive, this. Like that? No? Ah, okay. Sorry. Okay, just do next. Next slide. Okay, so where is will going us to? All of that things, like the redundant tissue, the adipose tissue, will make us to get the difficult airway. So what is difficult airway? difficult airway, according to the anesthesiologists, American Society of Anesthesiologists, is a clinical situation in which a conventional trained anesthesiologist experience difficulty with face mask or intubation or both of it. So when we have a hard time to do the face mask or hard time to do the tracheal intubation, then it's called the difficult airway. Okay. Then what other thing that we have to remember when we do we are doing the obese patient? First of all, we have to remember, like Walter Kim said, the reduction of functional reduction capacity, and then the reduction of chest wall compliance, and then there will be a high chance to become a microatelectasis. There are early airway closures and increased oxygen demand. All of that will get to rapid desaturation after induction. So, well, we do the induction after the pre-medication, of course, right? And then we do the intubation or managing the airways. There will be short time to become desaturation. So just so fast to become the saturation below 92%. Okay? And then the other thing that we have to remember of obstructive sleep apnea. This is what we have to remember to ask them, right? And then the obesity hypoventilation syndrome as well. Okay. So what we should do? Well, it's just like we are doing the ordinary patients. First of all, what we have to do the preoperative care. Well, we have to see how about the theromental distance, something that we always do every day, right? We remember, well, this one, what is the theromental distance, the ability to prognathe, and then the neck movement. How is the neck movement? See? So that this is what I said, when there is a more diffuse tissue in the neck or something like this, this will be more challenging, right? And then the mouth opening, and of course, like the hallmark of anesthesiologist Malampati. I've been do this since I'm internship, right? Okay, this is what you can do for physical examinations. Next. Okay, but for person with obese people, obese patients, we have to remember to ask them one thing about snoring. Snoring and obstructive sleep apnea has to be questioned. Well, you cannot ask into the patient, yeah? You can ask the wife or the girlfriend, okay? But be careful, ask this, because sometimes it's a long time you answer that, because it's really annoying, okay, the snoring thing. So we have to carefully ask about this. And then the second one, we have to do the measurement of the neck. How big is the neck? Okay. Next. Okay. Daniela, ini is a review on airway management in obese patients. You can search it in internet out of this. Okay. If a patient have OSA, then we need to do the stop bank questionnaire. See, in the stop bank questionnaire, what we ask is the snoring. Do you snore? Okay, or louder or something like that. Hey, is he tired when he's wake up in the morning? Or he has a how is the blood pressures? How is the BMI? Okay, and then how is the age, right? And the gender. And if the score is more than 5, it will be a significant risk for managing a difficult airway. Okay, for difficult mask ventilation, we can use the term obese. O stand for obese, B for beard, E for edentures, S for snoring, and E for elderly. Or we can also use M max. Right? Now this is just to make us easier to remember. Okay? So this thing, if we see what we need to see here, first of all we need to see this snoring, and then how about the BMI, the gender, the age, the neck circumference. This is what the neck circumference is. More than 43 in centimeters in around Adam apples for male, and more than 41 centimeters in females. That will be might be difficult airway. Okay. All right. That is for the physical examination. Besides physical examinations, we also can use, next slide, satu kali aja. Okay. We also can use USG. We also can use USG to do the predictions of the difficult manual ventilation. What we do, we try to make the distance. They measures the distance between the skin and the hyoid bones. So this is the hyoid bones, and this is the skins. And maybe later on or tomorrow you can try it yourself. If the distance is more than 1.4 centimeters, then it might be have a difficult mass ventilations. How about the laryngoscopy? Sebelumnya. Okay. How about the difficulty for laryngoscopy? Actually, Aruna Parameswari, he has get some study. The title is a correlation between preoperative ultrasonic airway assessment and laryngoscopic view in adult patients. What he found that there's a lot of prediction, like a lot of things that he used. There's a skin to hyoid distance, volume of the tongue, followed by the floor of the mouth, and the last is the skin to epiglottis. Out of all of this, the one that have the sensitivity and the specificity, the highest one, the highest sensitivity and sensitivity is skin to epiglottis. How do you get that? We do it like this. So we try to find a sign that called a small face sign. See, this is like a small face sign. This is the eyes, two of it, this is the nose, and this is the epiglottis. So we try to find the measure measures the distance between the epiglottis and to the skin. Okay. So, okay, no problem. Okay, skin to epiglottis. So if we try to find this, the small face signs, you have to put the ultrasounds in your trachea, like this, not trachea, in a thyroid, right? Yesterday maybe already on hands-on already know it, right? Yes. Over of that, and we will find these pictures, right? The two eyes is actually a thyroid hyoid muscles, thyrohyoid muscles, and this is the epiglottis, and this the air tissue interference. Okay, so next, the cut-off point is, according to the that one that is the cut-off points, the measurements, the length between the epiglottis and the skin is 2.54 centimeters, and for the in some others other study says that 2.75 centimeters. Okay. Next. But we must remember one thing, that preoperative prediction of difficult airway continues to be difficult up till now. In a large cohort study of a Danish database that consists of 3,391 difficult intubation, only 25% were genuine difficult intubations. Moreover, difficulty of face mask ventilation was unanticipated in 94% of the cases. So, what this is mean? This is mean up till now, the specificity and sensitivity of our current screening tool are still poor. That's why, if we are dealing with obese patients, we always must remember with this difficult intubation guideline and always be ready with the emergency trolley. Okay? So, in this difficult intubation guidelines, we are do laryngoscopy and fail. We try the supraglottic airway device. Of course, this will be in a trolley of airway emergency. And if it's success, we do that. That if we are not cannot do anything out of it, the last time or the last thing that we have to do is cricothyroidectomy. Actually, I have pictures for the cricothyroid, but tidak ada ya yang baru. I'm sorry for the inconvenience. Next. Okay, this one. When we try to do the intubations, of course, after we do the intubation, we have to make sure that the tube is already come in or not to the trachea. Right now, from the physical examination, we usually use the stethoscope, right, to see, oh, it's already get in. Oh, and it's not in a stomach or something like that. But in obese patients, sometimes it's hard to do that. That's why we can use USG to make sure that the tube is already in. Okay, so how we do it? We just put the USG probe here. It's so easy. You just put it there like that. Just so easy. And then, if the endotracheal intubation is successfully, the picture will be like this. You see, only one trachea. This is the trachea. See, just so only one. But if the endotracheal tube is going into the stomach, the picture will be like this. This is the trachea, and this is actually the tube that come into the stomach. So this is called next
5 minutes.
Yeah. Next again, double meteors. That's what they call it, because it look like a meteors. Okay. Next. Second things that I would like to share is for a percutaneous cricothyrotomy. This is so easy. Very, very easy. You just put the probe, right? The probe is like that, and this is the position of the probe. If you do it, the probe like this, you will see the picture like this. See these pictures. If you find this pearl, something like this, that is the trachea. From the trachea, you try to find the cricoid. This is the cricoid, and then the thyroid. This is the cricothyroid membrane. This is a place where you can do the percutaneous cricothyroidectomy. You can use needle or you can use scalpel out of it. Okay. This is the cricosteroid membrane. See, by this we can see. Oh, we mark the sites. Why this is important? Why? First of all, in an obese patient, it's hard to palpate. That's one. The second one is, you see these patients with a difficult intubation. Sometimes, if we see the midline, we will see it here. But when we use the USG, we will find that it's moved over here, the trachea, the cricosteroidotomy. The place for the cricosteroid membrane is moving. So this is what I said. It is important to mark site where is the cricosteroid membrane. So in an emergency situation, we can do that. Okay. I think that's all I can say for the take-home message. Next, take-home message. I just gonna say that this obesity is increasing in number right now. So the chance for us to dealing with this obese patients in operating room will be increasing. Obesity is a risk for difficulty airways. Perioperative evaluation is important, and perioperative care for evaluation can be done by a physical examination or use ultrasounds. And the most important one, when intubating obese patients, emergency trolley for airway management must be ready. Okay. Okay. Thank you very much. I think that's all I can say. I hope it's. Okay.
Thank you very much, Dr. Gus Krishna. Very nice. Perfect presentations. And now, well, last but not least, the star of today. Actually, the star of our running team. We cannot match you. And we hope that your knowledge would support us more. Dr. Anuraju will present us about the updates in the obstetric anesthesia. Dr. Anuraju is the senior in Adelaide Hospital, the friend of Dr. Chahya, and he's been in collaborations with us since the BCCM since 10 years ago. So we have put his photo, the younger ones, on top, if you wish to know the before and after. But we would like to say thank you very much that Dr. Anuraju always have the time to give some lecture to us each year, annually. So Dr. Anuraju, this is your turn, and thank you.
Terima kasih. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya. Terima kasih banyak atas undangannya hari ini. Saya senang sekali kembali ke Bali dan bertemu dengan kalian semua. Hari ini saya akan berbicara tentang apa yang saya pelajari di konferensi Obstetric Anesthesia Association yang saya hadiri bulan November yang lalu. Konferensi ini diadakan Westminster Abbey. Inilah Westminster Abbey. Di gedung itu namanya, inilah Westminster Abbey. Gedung itu namanya Church House. Church House konferensi ini diadakan di Church House di dekat Westminster Abbey. Westminster Abbey di mana kita memiliki coronation Raja Charles. Raja Charles minggu yang lalu. Di dalam Church House ini terletak kantor-kantor di Bishop of Canterbury dan imam yang paling penting di gereja Westminster Abbey. Pertama-tama, terima kasih banyak untuk atas hiburan Anda tadi malam. Itu sangat menyenangkan sekali.
Terima kasih banyak.
Pleasure. Terima kasih.
Terima kasih.
That's the star.
I don't know.
The rock star.
I know,
that
rock
one.
star, same, but I think it's wonderful. I think you guys have terrible,
Until the last breath.
excellent talent. I don't know. I don't think we can match that. I don't think. So hats off to you, all of you guys. Terima kasih banyak untuk mengisikan saya atas berlatih bahasa Indonesia. Bolehkah saya dilanjutkan presentasi saya di dalam bahasa Inggris? Thank you very much. It's a good chance to practice my Indonesian with you guys. So. All right, fantastic. So this is the conference that I went to last November, and then you get lots of information in this talk. It's just an update on what I learned, the notes I've taken to the conference. It's just a bit of expansion from the notes that's there. There are some QR codes in this, which is very good. Like you can scan it and you can get it in your phone. So there are some QR codes, so make sure you scan them if you want to. It gives you some information of the articles that you're talking about. And if you need more information, just ask me later, and I have access to the meeting slides. So I'll try to answer them for you. So what's included? So there is always a lecture that starts, the conference starts with what's new in obstetric anesthesia. So this is a good QR code that you can scan if you want to. So this was a lecture by Michaela Faber from the United States of America. So she is gone through about 89 journals, 1,398 manuscripts. And she had a lecture on Society of Obstetric Anesthesia and Perinatology Conference, which Kim's just back from. So this was last year. He came from US to Sydney, rather than going to Adelaide, he came straight to Bali. So hats off to this gentleman, right? So he's coming straight from US to Indonesia for this conference. So hasn't gone home. So this is a good, so they got lots of information. So all these articles been sort of crunched into about 15-page summary. So you can get a good information from this QR code. The lots of articles that's been published in 2022, it's in there. So some of the articles that were there, like when the world was reeling with COVID, a bombshell article came into this field of obstetric anesthesia. So an article was presented in JAMA, like just a Journal of American Medical Association Pediatrics, and it said that it's a well-conducted, it's a study from America which looks at about 200,000 patients. And the study concluded that if you have an epidural, there is a 37% chance that your child may be autistic. So there's an increased risk of autism if you have an epidural. That means that it's a very, very significant number. It's about 1 in 3 chance that your child can have autism if you have an epidural. That's just from the study. So that all the organizations like Obstetric Anesthesia Association, Society of Obstetric Anesthesia and Perinatology, everyone just went bonkers. It's just a huge media backlash. Media report on that, when you have an epidural, will you become autistic or not? So then it was COVID, so people had a lot of time. So there are lots of counter studies that came up in 2021. Saying that that study had a lot of assertment bias, lots of selection bias, residual confounding and misclassification of autism spectrum disorder. And that study was sort of basically thrown out. So be assured, if you have an epidural, you're not at a higher risk of having autism. All right, so there are lots of other well-conducted studies that shows that there is less chance of having autism. The maternal mortality report of the UK came down, which shows that cardiac disease is the higher chance of, is the most cause of mortality, followed by seizure and stroke. And direct causes venous thromboembolism, sepsis, hemorrhage, and suicide. And that was the maternal mortality study from the UK. So in that maternal mortality study, the maternal mortality rate of UK was 8.8 per 1,000 live births, and 37% of the maternal mortality was due to deficiency in care. But In this mortality, more black Asian populations were quite affected. Maternal mortality of USA has also come up. It's about 23.8. And then again, you can see 55% of the women who died were black, when compared to 19% of women who were white. So in the UK, so both of them, if you have a black or a Asian patients, both of them are getting same care. So, but something's happening, like if you're a white or a black patient, they're going to the same hospital, they're getting the same sort of care. So what's happening there? Like something is missing, like more people who are in the black population is dying, more people who are white population are not dying. So there's a sort of a 5-step approach to healthcare where we have to listen, make sure that what you say is communicated properly, remove barriers of communication, check you are providing clear information, provide access to detailed documentation, and be a champion is something that 5-step healthcare for professionals been. So this is something that someone asked me yesterday. One of you asked us regarding whether you can give a spinal in thrombocytopenia in a patient who's having a HELP syndrome. So this would sort of, this article answer you that question. So this is an evidence-based statement from the Society of Obstetric Anesthesia and Perinatology on thrombocytopenia. It says more than 70,000 is relatively safe. We have taken a blood test, have a platelet count of more than 70,000 in the last 6 hours, you are relatively safe to give a spinal anesthesia. So if the count is about 50 to 70,000, then you have to weigh the benefits of giving a spinal anesthetic versus the risk of having a GA. Suppose you're having a patient with a very difficult airway, who's having a, which you feel that you'll struggle to put a tube in, and the platelet count is say about 60,000, then you might tend more to give a spinal anesthetic in that patient. Or if it's a very thin patient who's very slim, it's got a beautiful airway, and the patient platelet counts about 60,000, I might say, all right, we can, giving us GA is much more safer than doing a spinal in this patient. So we have to weigh the 50 to 70,000, we need to weigh the benefits of giving a GA versus risks of having, like, you know, MBA hematoma. And if you have HELP syndrome, that's something some people have asked, someone would ask me yesterday. HELP syndrome is a syndrome of platelet consumption. So your platelet, if you've taken platelet now, the count is about 100,000, you wouldn't know what the count is 2 hours later or 3 hours later. It's because the platelets getting consumed because of the preeclampsia of that patient. So, so in caution, you need to be very, very cautious when you're doing a spinal in HELP. Like if you do a spinal, if you're taking a blood test 1 hour ago, you wouldn't have a clue of what's happening with a blood count later on. So you would tend to not to do a spinal in HELP syndrome if the counts are really, really low. And we always look at the trend of how severely the trend is falling. So it's just not a number, you look at the trend as well of the platelet before you decide on whether you need to give it a spinal. So before we go further, I'll just explain some terms that I'd be using. As far as I know, you guys are not familiar with epidurals and epidural analgesia. So this is a chart from our, it's a cheat sheet, which is stuck onto our, this is our epidural management chart, which is stuck onto our epidural trolley. And that was, you can see the sign here, it was done by Kim Osborne when we introduced, it's done in 2014. So he was the head of the department there. It was done in 2014. It still sticks on the epidural chart as a cheat sheet. All right, so people can know what to give, what to write up for. So we use ropivacaine, 0.1% fentanyl, and 2 milligrams per mil. And the initial order is 10 mils every 20 minutes. So that is the bolus that the patient presses if they are uncomfortable. All right, if you do an epidural, we connect them to 0.1% fentanyl with 2 micrograms of fentanyl, and every time the patient is uncomfortable, you push a button, so 10 mils every 20 minutes can be given. Like if the patient presses twice, they will get 1 dose, and the next dose will be given after 20 minutes. Right? Just like your PCA. You use PCA, don't you? So just like PCA, you use 5-minute lockout interval. This is what 20-minute lockout interval is what we write. So this is the PCEA bolus, all right? PCEA bolus. On top of that, the machine has another feature. It gives 5 mils every hour. Every hour it gives 5 mils each. So that is called programmed intermittent epidural bolus. All right, so PIEB, or programmed intermittent epidural bolus. So that's that component. So you got a PCA component and a PIEB component, and then we have an additional 10 mils that the midwife can give every hour or so, so that the patient can get comfortable. If the block's not covered properly, you give another 10 mils. So this is important. So this terminology, PCEA, PIEB, are important in the next couple of slides that I'm going to talk about. So as you see, so initially you set up an epidural, you give a bolus, get patients comfortable. So 1 hour later, the 5 mil PIEB goes in. Then 1 hour later, another 5 mil PIEB goes in. All right? The patient can push a bolus here, push a bolus here, push a bolus. Every 20 minutes, the patient gets a bolus. They can push and get a dose if they want to. So if the PCEA is very close to PIEB, that is delayed by another hour. The PIEB is delayed by another hour. All right? So that they don't get 10 plus 5, 15 mils altogether. All right? So, and so another thing that we do that's coming up in the literature nowadays is a dural puncture epidural. All right? So you remember, it's just as you do combined spinal epidurals, don't you? Do you guys do combined spinal epidurals? Dural puncture epidural is nothing but combined spinal epidural without putting any drugs. All right? So you do a combined spinal epidural, just put a hole in and pull the spinal needle out. All right? And then you thread the epidural catheter in. So you do a epidural, put a spinal needle in, don't put any drugs. If you put drugs in, it is combined spinal epidural, because when you put the drug in, the patient will get comfortable. All right? Immediately, the spine acts very quickly. Epidural takes time. You know that, isn't it? You know that spine acts quickly, epidural takes time. So the spine acts quickly, and the patient gets quite comfortable. And then you put the epidural catheter in. You don't have any idea where the epidural catheter is going. All right? And then after 20 minutes, 1 hour or so, that epidural sort of spinal wear off, and if the patient is uncomfortable, you haven't tested. So you have an untested catheter just by threading your epidural catheter in. Just by putting a spinal in, you have an untested catheter. So if you prevent that, doing something called as dural puncture epidural, just put a hole in the catheter. I'll come to that in a second. Just put a hole in the spinal, in the dura with a spinal needle, and come out without putting any medication in, so that you can test your epidural catheter. That's what you want to work. You want the epidural catheter to work later on, especially in instance of morbid obesity or cardiac disease. You really, really want the epidural catheter to work. You employ something called as dural puncture epidural. I'll come to that in a second. So, so they've done, this is a study that come up, dural puncture epidural versus epidural for initiation. That's like the initiation of labor analgesia. CEI is continuous epidural infusion. You give an infusion continuously. So, or PIEB. PIEB is programmed, that's what we talked about, programmed intermittent epidural boluses. PIEB is, so difference is 5 mils per hour or 5 mils every hour. PIEB is every hour you get 5 mils, one next hour you get 5 mils, you get next hour 5 mils. Does it make a difference? It does. We'll come to that in a second. All right? So this study found out that DPE, like dural puncture epidural, with programmed intermittent epidural bolus are superior because it's fast onset, it's motor sparing, so you don't get much motor block, and there is no increase in side effects. All right? We'll talk about that in a second. So this is what it shows. Like if you put a hole in the dura, what is happening is your medication that you put in the epidural space is going through the hole into that spinal space, and it gets and you get an action. So you can see this is a gauge with a 27 gauge. There's not much transgression of local anesthetic, but you have a 24 gauge or an 18 gauge. There is more transgression of local anesthetic. So the higher the caliber of the needle where you put the hole in, the bigger the transgression, like the bigger the transmission of local anesthetic from the epidural space to spinal spaces. So 27 gauge may not work properly, so we tend to do more, if you do a DPE, they say 24 gauge or more would be better. So I usually do a 24 gauge if I do a dural puncture epidural technique for a labor analgesia. All right, so that's about it. So we'll come to that DPE in a second later on. So there are other studies shows 30 degrees left lateral uterine tilt works, decreases vasopressure use. You can use prophylactic uterotonics. There is no benefit in decreasing postpartum hemorrhage. So if you use just prophylactically, if you use oxytocin, there is no benefit in decreasing postpartum hemorrhage. Quadratus lumborum and TAP blocks. If you use intrathecal morphine for your analgesia in labor, if you TAP and quadratus lumborum block is not that effective. Do you guys use intrathecal morphine here? For cesarean section analgesia, do you use intrathecal morphine? Yeah, so if you use intrathecal morphine, we use intrathecal morphine in all of our majority, almost 99% of our patients get. We get, what we put is heavy bupivacaine, 2 to 2.3 mils, 15 mics of fentanyl, and 50 to 100 mics of intrathecal morphine is what we use. And that gives good quality pain relief. And they use regular Panadol, regular Voltaren. And they very minimal oxycodone is required later on. So intrathecal morphine works really, really well, even though they have some side effects of nausea and vomiting and things like that. But that can be covered with anti-nausea medications. If you use intrathecal morphine, the studies have shown that, mind you, these are all summaries of studies, all right? That's why I'm carrying on. So there's no benefit if for TAP blocks or quadratus lumborum block if you have. Postural puncture headache, there is 73% epidural rate in the US, and there in the US the postural puncture rate is about 1%. And there is a new mechanism of headache proposed for your postural puncture headache. It means that when you have a hole in the spinal, there is intracranial hypotension, and that causes intracranial nociceptive activation, and that it causes trigeminal neural sensitization. So that's one new mechanism procedure. You heard about tranexamic acid, use it quite a lot. A big study came as a woman trial which shows that there is 30% reduction in mortality. That was in about 2017. So people started using tranexamic acid for all scenarios like elective cesarean sections, elective childbirth, to see whether there is any decrease in postpartum hemorrhage. There is a study called a TRAP study, TRAP2 study, which was, TRAP1 study was for normal childbirth. They used prophylactic tranexamic acid. They found no difference in postpartum hemorrhage. The TRAP2 study was done for elective cesarean section. They give prophylactic tranexamic acid to see whether they can decrease the amount of postpartum hemorrhage, but there wasn't any decrease in postpartum hemorrhage. But if you give tranexamic acid, the patient who had tranexamic acid has a higher chance of postoperative nausea, vomiting. So if you don't have hemorrhage in a cesarean section, don't give tranexamic acid unless and until as a prophylactic measure. Another study that came, so in South Africa, the ampules of tranexamic acid and bupivacaine look similar. You can see it's just tranexamic and bupivacaine ampule. They look similar. So that's a huge, there's a very high chance of drug error. So, but the problem is, so there are lots of tranexamic acid has been given intrathecally as accidentally, and there is 86% mortality rate with intrathecal tranexamic acid. All right, so intrathecal tranexamic acid is about 86% mortality rate. So it presents as failed spinal. There's severe pain in lower limbs and buttocks. There's myoclonic jerk, seizures, and the patient goes into cardiac arrest. No one knows why it happens, but if you give intrathecal morphine, so intrathecal tranexamic acid, there's a high chance that your patient is going to die. So luckily, I don't think your packaging, our packaging comes in 10 mils. How's your packaging of tranexamic acid? Similar, is it? All right, so be careful then. So be very, very careful if you're packaging. Our tranexamic acid comes in 10 mils. So if you give tranexamic acid, your patient is going to present as failed spinal, severe pain, lower bunking, and then you get myoclonic jerking, and the patient gets cardiac arrest. So that's 86% mortality rate from South Africa that's come up. So be careful. If your ampules look similar, be very, very careful. It's high risk of mortality with tranexamic acid intrathecal. What's new in obstetrics? COVID vaccine efficacy, 15% decrease in stillbirths in mRNA vaccine. Stillbirth, 2% increase in Black, 50% increase in Asian, and two times increase in deprived areas. And elective induction, if you induce the patient electively at 39 weeks versus expectant management, there was decrease in perinatal death by 73% and decrease in NICU admission by 20%. So all these prompted the National Institute of Clinical Excellence, because there is to develop a statement saying, consider induction 39 weeks for Black, Asian, and ethnic patients, and you can see how the media is going to take that. If you and that's in the UK. Say Black, Asian, consider, so it's like gender, like a race bias sort of thing, sort of a racist comment like thing came up. So they have to rephrase the statement to low risk, consider induction to low risk pregnancy according to ethnic, social, and economical backgrounds. So induction of agent of labor or emergency section. Induction of labor is a marker of proactive care. Emergency section is a labor marker of acute care. If the hospital with higher induction of labor has a better perinatal outcome. So there is no difference in lower segment cesarean rate if you induce the patient electively or do an emergency cesarean section. Again, we'll come down to epidural versus combined spinal epidural. The US survey, 45% of epidurals are CSCs in the US, but there is no benefits between CSC or epidural, and there is no consistent benefit between CSCs and epidural done by a Cochrane review by one of Kim's and my colleague called Scott Simmons, who is working in Melbourne at the moment. So he was working in our department, he's moved over to Melbourne. The problem with CSCs is gives you instant pain relief, but there can be fetal bradycardia. So that's why CSCs aren't that popular. So because you take the pain away completely. So when your patient is in labor, you have two hormones. You have oxytocin, because the patient is laboring, and it's also adrenaline. When the patient is in pain, you have a stress hormone is released, that's adrenaline. So adrenaline does two things. Adrenaline is like oxytocin is a vasouterotonic, it contracts the uterus. Adrenaline is just like your salbutamol or terbutaline that you give us. It's a beta-2 agonist, it relaxes the uterus. So you take the pain away completely, and all of a sudden there is too much oxytocin, too little adrenaline. So there is unopposed oxytocic activity. So the oxytocin goes and contracts the uterus, and there can be fetal bradycardia. So about 5 to 15 chance of fetal bradycardia if you have, if you do a combined spinal epidural. But that is not that significant. It is resolved by simple measures. There's no statistical significance from a bradycardia point of view. And oxytocin administration independently increases the incidence. But one thing about that fetal bradycardia, if you give sufentanil, there is an increased chance that you can have a fetal bradycardia. So I don't think the mechanism that I've explained earlier would fit in here. It's sort of, still the mechanism is sort of unclear. And if you have a rupture of membrane or increased dilatation of cervix, you have an increased risk of fetal bradycardia as well. Dural puncture epidural, sort of, since you're not putting anything in there, decreases the risk, there's less, like if you put fentanyl in the epidural space, the patient will feel itchy. So there's less, so if you're not putting anything there, so you can have less pruritus, less hypotension, less hypertonus, and there's a higher chance that your epidural would work. So consider DP in situations like morbidly obese, where you want the epidural to work, you want the catheter to be tested properly, or in maternal cardiac diseases. So maintenance of local analgesia, the dilute local anesthesia with lipophilic opioid, that's fentanyl or sufentanil is the gold standard. You can have manual intermittent top-ups, that's the PCA component that I've talked to you about. And it's a background epidural infusion, that's a PIEB, which can be either continuous or boluses. So if you give continuous infusion, there is a higher chance of motor block. All right, so that's why you're trying to avoid. I'll explain that in a bit detail in a second. So the first one is 10 mils per hour. So you can, every second you get a drop, a small drop that goes in and in and in. It forms a small puddle there. But if you give 10 mils every hour, it comes as a bolus, and it sort of spreads into the local, into that epidural space. And once it's in the epidural space, it gives you better coverage. All right? So that's why we tend to adopt this every hour rather than 10 mils per hour. 10 mils per hour every drop, it just goes in one. Every second a drop goes in and forms a small puddle. So there's a lesser spread with 10 mils every hour. And if you look at this space, this is every second a drop is coming. All right? So that's so there's always a gradient. This is inside the nerve, this is outside the nerve. Every second there's always a gradient of local anesthetic inside that goes into the nerve and it can cause motor block. While if you give 10 mils every hour, it comes in there, it spreads in, and it sort of disappears. So there's no gradient, so there is less chance of motor block with your PIEB boluses. So that's why we give it 10 mils per hour, every hour rather than 10 mils per hour as boluses. So 40-minute PIEB is optimal. We tend to use it every hour. The block remained high but didn't go up drastically. In Singapore, they are developing a model where the machine can adjust itself. Like, the patient is pressing too much, then it will increase the boluses. The patient is not pressing too much, the machine will automatically decrease the bolus. So they're developing a model that's not in the market yet, but something to watch for in the future. Remifentanil PCA, lots of randomized controlled trials. It says inferior to epidurals. So about 9 apneas, easily resolved with simple interventions. You need very, very close monitoring. And there is a trend to lower the boluses these days. And so this is a case report from Manchester where remifentanil is routinely offered at a lower boluses. It's 92% patients were satisfied in that circumstance with the lower boluses, with 5 to 10% epidural conversion rate, and only 4% desaturation was experienced. So they are more in favor of giving, even though it's not superior to epidural, there is an option to give lower boluses, and then you can escalate if need be to decrease the amount of apnea that the patient can have. Epidural and increased risk of operative delivery. There were old studies, previously we were taught, if you have an epidural, there is an increased risk of patient having a cesarean section, there is an increased risk of patient having forceps delivery and so. That was in the days that we used very high concentration of local anesthetic, like 0.25% BPV gain. All those studies came up then. But nowadays we're using very, very low concentration of local anesthetic with lipophilic opioids like fentanyl. So the recent studies and Cochrane reviews show that low concentration is no increased risk of epidural and operative delivery whatsoever. You have time? 5 minutes, okay. All right, just going a little bit. All right, fever and epidural. Yes, fever is an association with epidurals. Mechanism is unclear. There's no neonatal brain injury. The outcome of studies are reassuring. The large retrospective studies came up in 1976, 1982. They're looking at about 400,000 subjects, and they show that even though the patient has fever, there is no significant adverse outcome with women with epidurals, and there is no evidence of autism, because that's one of the risks that was proposed for autism. Is if you have a fever, the patient's brain can get can have brain injury. The mother has fever, fetus is also going to have an increased temperature, so they can have neonatal brain injuries. So that was one of the proposed mechanism of epidural. But in these studies, there's no evidence of, large studies, there's no evidence of fever, association of fever altogether, autism altogether in kids. All right, coming on to Dr. Krishna's talk, point of care ultrasound. What do you do in case of, what do you do with ultrasound in theater in obstetrics? One is identifying cricothyroid membrane. We had a beautiful lecture by Dr. Krishna, so that's one of the things. Identify esophageal intubation, which again Dr. Krishna has shown us. Gastric, this is one of the things that is coming up, gastric ultrasound. Just have a look, gastricultrasound.org. It's very, very that's looking for gastric volume to see whether you can safely intubate this patient or not. Gastric ultrasound is something that's coming up. And looking for pneumothorax, as the use of ultrasound in obstetrics in theater. This is just a nice thing that I found. Early dreaming, ERAS is drinking, eating, and mobilization. It's one nice terminology that I found for ERAS. Early dreaming, drinking, eating, mobilization. And remember to redose antibiotics every 1 and if you have a hemorrhage of more than 1.5 liters, your antibiotic levels go down further. So remember to redose your antibiotics if the hemorrhage is more than 1.5 liters. All right, what else? Epidural failures, yeah, I think it should be fine. I don't know much epidurals. CSEs versus epidurals in emergency cesarean section. CSEs is better than epidurals, only one studies, but it's not replicated by the other studies. Spinal anesthesia after epidural loading. Best local anesthesia for epidural top-ups is lignocaine plus bicarbonate, about 13.4 minutes. What else? Bicarbonate, 1.2 mils of preservative-free soda bicarbonate, 15 mils of lignocaine is what they advocate for enhancing the local anesthetic action. Yeah, uterotonics in cesarean section. Rapid homogeneous desensitization of oxytocic receptors following oxytocin receptors happens. So receptors get internalized within 2 minutes. So require different doses for labor and elective cesarean section because your receptors get primed. So the dose finding studies for elective cesarean section, they use only 1 unit bolus is what they've found out, and repeat 3 units according to receptor sensitivity if need be. Intrapartum section is 3 units of oxytocin. I just go through this. Carbetocin dose finding studies is about, you don't use carbetocin here, don't you? So I don't think we'll go with that. Yeah, this is a nice QR code if you want to scan. It's a good recent study on obstetric anesthesia and heart disease. It came up in 2021. So it's a nice review article on cardiac obstetric anesthesia and heart disease. All right, it's a good review article which you can scan. All right, so new gadgets, initiatives that we found. So this is a new, just unlike ROTAM, this is called as a hemostatic system, contra hemostatic system. It sort of has different terminology. CT is clotting time, CSL is clot stabilization to lysis time, CS is clot stabilization, PCS, and this is what I like about it, it's called PCS, it's platelet contribution to clot stabilization. Yes, platelet contribution to the clotting time, and fibrinogen contribution to clotting. So you can see, so if PCS is less, it means that you need more platelets. If FCS is less, then you need more fibrinogen. So this is something that they found. That's something that's more interesting than ROTAM. Then ROTAM, you go look at FIBTEM, and all the other things like, XTEM, INTEM, FIBTEM. Can be a bit complex. So this one you say, so you can go, if you have a problem with fibrinogen, if FCS is less, it means that I need to give fibrinogen. You don't have to think more, like, you can just go ahead and utilize that. So that's one. There's another one, point of care fibrinogen testing that I found in the trade center. It's another thing to prevent, it's called as a PPH butterfly. So in order to do bimanual compression, they're developing a new gadget called PPH butterfly. So that acts as a fist. So this can just, instead of putting a fist in, you can put this in and compress it. So it's called as a PPH butterfly. Riboa is resuscitation of endovascular balloon occlusion of aorta. So we have postpartum hemorrhage. You can thread this Riboa from the groin over here and occlude the balloon so that there is less blood that flows into the uterus. And we can sort of repair the uterus and then like release the balloon, and then there will be more stuff. We don't have any exposure to these things. So the best thing to do from your point of view and any point of view is do manual aortic compression, so that buys you some more time. Not going down to, you don't use Muse chart and stuff. All right, this is important. All right, so this is a video laryngoscopic view, all right? What's that? What do you see there? That's a vocal cord, isn't it? I got an answer here that says that's a vocal cord. Are you sure it's a vocal cord? Pretty sure, is it? How about now? How about now? So that is actually the esophagus. All right? So this is a term that's coming. It's called as glottic impersonation. So you put a laryngoscope in, you give a big force. All right? If you give a big force, there can be like less vascular. The esophagus gets stretched, so the opening of the esophagus can get stretched, and once the opening of esophagus gets stretched, get blanched. So in the hurry, you might think that it's an esophagus. So you might think that's vocal cord and put the tube in there, and then keep on ventilating the patient. And you can keep on ventilating the patient, and then patient becomes bradycardic, and you say, I saw the cord and it's gone in there. So that's why there is a new consensus statement. You can scan another QR code there. So prevention of unrecognized esophageal intubation, which says that you need to recognize esophageal intubation. So always monitor exhaled CO2. Routinely use a video laryngoscope. The airway operator should verbalize and view at the laryngoscopy. So always double check with your nurses or the registrar who's with you that there is CO2 going up, and it's and requires esophageal intubation to be actively excluded. So there are some tips for you to. You can scan that QR code if you want to, and you can have a look at that statement. All right. So if you recognize video difficult. If you think that the tube is in the esophagus, you exclude that the tube is in the trachea. Don't use any of your auscultation or chest movement. Don't use, what they advocate is don't do anything clinical that you would normally do, like don't auscultate. Don't look at misting of the tube. Don't look at chest moving up and down and things like that. So what you have to do is do a video laryngoscopy, or you can use a flexible bronchoscopy, or use an ultrasound and look at what Dr. Krishna told us. You can see to the double barrel sign that Dr. Krishna has told us about. So you can see the two tubes. So here the tubes in the trachea. Here this is a trachea, and this is your endotracheal tube in the esophagus. So you have to do these measures, and they don't advocate to use anything clinical in this aspect. So the learning, what I found was what we do at the Women's and Children's is contemporary, in accordance to practice in world leading centers, evidence-based. More reassurance on subarachnoid block after epidural failure. Epidural fentanyl after adequate top-up with local anesthetic, what I do. Dual puncture epidural for morbidly obese patients with cardiac comorbidities. We don't use remifentanil in the Women's and Children's, but Kim's Hospital now uses remifentanil, so revisit. Because we had problems. This is all political, I'm not going to that. Use of bicarb with lignocaine, double checking with anesthetic nurse regarding oxygen trace, CO2 trace. Emphasize how to kill compression with surgeons to buy time, and teaching element to play with that into modification. That's about it. Terima kasih banyak. Om Shanti Shanti Shanti.
Super. Thank you very much,
Makasih.
Dr. Anuraju. We go straight to the discussion. We have so many questions. So I am so confused which one that I should go first. But okay, let's start from Dr. Cahya first. Ada pertanyaan. There's a question about what is the most suitable post-operative analgesia for obesity patient after cesarean section? Kalau kita nggak pakai opiat, terus yang paling bagus pakai apa? What's the best suitable post-op analgesia for patients that had cesarean sections without opiates?
Terima kasih, Sin. Jadi pada prinsipnya OVA itu menggunakan multimodal, itu tapi di luar opiat, ya, di luar opiat, atau menggunakan opiat tapi less atau sedikit. Itu pun diselektif pasiennya, ya. Kemudian regimen yang biasanya digunakan adalah Dex, paracetamol, low-dose ketamin. Kemudian post-op-nya kalau bisa regional anestesi, misalnya TAP block, KL block, dan lain sebagainya. Jadi lokal anestesi bisa epidural, bisa block, selective block, dan lain sebagainya. Intinya tidak menggunakan opiat. Jadi biasanya yang paling disering digunakan adalah dexmedetomidine, ketamin, paracetamol, NSAID ini, dan lokal anestesi. Tapi saya sudah pernah coba pasien seatiroid, kita coba tanpa dex bisa, tanpa dexmedetomidine bisa, ya. Jadi multimodal, tetapi kombinasikan dengan blok. Itu. Makasih, Sin.
Dr. Satrio atau Dr. Gus Krisna mungkin ada tambahan?
Ya, sebenarnya intinya kalau saya intinya benar kata Dokter Cahya ya, kita tetap multimodal analgesi karena tujuannya untuk tadi mempercepat pemulihan. Nah, kenapa kita menghindari opioid kan karena untuk segera dapat motilitas usus dan mobilisasinya lebih cepat. Kalau dari kami biasanya memang lebih mengutamakan, ini dari pengalaman aja ya, sharing, kita biasanya pakai tab block, dan ini kita lagi mendalami dengan penggunaan TENS, dan dalam penelitian kayaknya hasilnya sama bagusnya. Jadi semakin banyak variasi yang bagaimana caranya untuk menghindari penggunaan opioid yang berlebih. Demikian, terima kasih.
Terima kasih, Dr. Gus. Next questions for Dr. Anuraju. There's a question about how to optimize the use of epidural in patient with pregnancy and obese, considering that the use of opiates can be limited as well. How can we maximize the epidural for obese pregnant patient?
I guess with the doses that we use for epidural analgesia, that's for analgesia or pain relief for cesarean section. What do they want? Like, do they are they talking about analgesia? Sorry, I was just asking a question about analgesia for labor or pain relief for after cesarean section.
I guess this is related also with the opiate free, but also related with the epidural. I guess maybe regarding your
analgesia, I didn't talk about cesarean section anesthesia.
Yes.
The thing is, with the epidural, there's no difference of optimizing analgesia with a patient who had who's obese or who's non-obese. From my perspective, I might do a combined spinal epidural, dural puncture epidural in an obese patient to make sure that I am in the midline, and there is a higher chance of my epidural to work. But the doses that we use from an opioid perspective, it's just 2 microgram per mil, and that's not shown to cause any respiratory depression in patients who are obese. Like, it's a lipophilic opioid. Fentanyl is a lipophilic opioid. So the main use of fentanyl doesn't act centrally. Morphine it's a lipophobic opioid. It goes in the remains in the systems. Goes in the mechanism of morphine is it goes into the CSF and goes into the brain from the CSF and causes central action. But the mechanism of fentanyl is immediately it goes into the spinal or the epidural. It goes and clings into that spinal cord, and it gives improved analgesia. So we're not putting any intrathecal morphine in these patients. We're using about 2 micrograms per mil of fentanyl, and that's not shown to cause any problem, any respiratory depression from an obesity point of view. That's what they were concerned about. And even with the doses of 100 to 150 micrograms of morphine in the spinal space or the epidural space, if it's epidural, we put about 3 milligrams of morphine. 3 to 4 milligrams of morphine for post-cesarean section analgesia. With spinal, we put about 50 to 150 micrograms of morphine. And even those doses are not shown to cause any respiratory depression or aggravate obstructive sleep apnea, even though we monitor them closely in a high dependency unit if they have a morbidly obese patient having a cesarean section. To answer the question, there is not much difference. I might considering doing a combined spinal epidural so that my spine or a dural puncture epidural so that my epidural works better, as well as there won't be any change in local anesthetic that we use with fentanyl.
Okay, thank you. Dr. Kim, do you have anything to add?
No, exactly what Anu said, because it's the epidural, pain relief is different from cesareans.
Okay.
I think it's really clear.
Yeah.
And I'm with Anu. I think that just considering that dual puncture technique possibly, but I think that before that's implemented, you have to have a whole process around it.
Thank you. Dr. Gus Krishna, ada pertanyaan, there's a question how to choose sedative drugs in obese pregnant patient to prevent OSA. That's a tricky question.
How to choose?
How to choose which one? Which one is the best sedative for obese pregnant patient with OSA, stop bang score, high risk?
For the simple answer is dexmedetomidine actually.
Okay.
That is actually the answers because that's I think we do the weak intubations. This is good for using a dexmedetomidine. Jadi dengan dexmedetomidine itu pasien menjadi lebih tenang, kemudian dia masih kooperatif dan dia tidak mempengaruhi respirasi. Jadi saya kira dexmedetomidine kalau untuk sedatif ya, untuk paling enak untuk digunakan untuk managing airway. Kemudian kalau yang penting itu sih sebenarnya kalau kita mau fiber optik ya, yang awake itu ya dalam artian ya ininya yang paling bagus lokal anestetiknya. Jadi bagaimana kita menggunakan lokal anestetik, kalau dia sudah lokal anestetiknya bagus, maka sedasi yang dalam itu malah tidak kita sarankan ya. Kalau mau kita awake ini ya. Kalau ini tujuannya kalau menanyakan sedasi intinya kan supaya pasien nyaman ya. Intinya ke sana arahnya ya kalau saya dalam pendapat saya. Nah, kalau misalnya kita mau pasien itu nyaman, yang pertama itu adalah anestesinya, masuk dalam anestesi lokalnya. Jadi bagaimana kita mendapatkan anestesi lokal yang baik pada saat kita melakukan awake fiber optic. Kalau udah itu bagus, ya aman. Jadi kalau kita berbicara mengenai bagaimana melakukan topical anestesi yang baik pada awake fiber optic itu adalah yang pertama itu kita harus tahu bahwa airway itu ada 3 nerve ya yang harus kita atasi. Yang pertama itu nerve number 5, nerve number 10 ya. Bagus ya. Nah, kemudian yang terakhir itu yang nomor 9 lah, tapi ya nggak terlalu yang nomor 9. Nah, yang 2 ini mungkin ya. Nerve yang atas ya, yang nomor 5 itu bisa kita atasi dengan nebulizers ya. Kita bisa pakai itu atau kalau kita mau kita pakai silokain or something like that. Dan yang paling enak itu biasanya kalau kita mau itu pakai kayak apa itu namanya Dokter Cindy? THT mereka pakai tampon block. Nah ini biar nyaman di hidung ya, itu yang pertama. Kemudian untuk nerve nomor 10 itu ada 2, yaitu yang kita harus atasi adalah superior laryngeal nerve sama recurrent nerve ya untuk yang ininya. Untuk superior laryngeal nerve itu sebenarnya kita bisa melakukan block. Jadi itu di vocal cord ke atas ya, dari vocal cord ke atas itu dia pakai superior laryngeal blocks ya. Mungkin saya tadi nggak sempat ngeliatin ya. Itu bisa dilakukan. Jadi kalau mau blind boleh, kalau mau pakai USG juga boleh. Tapi kalau untuk recurrence, jadi yang bagian untuk ininya ya, dari vocal cord ke bawah, jadi recurrent nerve ya. Untuk yang apa namanya, kan ada motorik sama yang untuk ini ya, untuk baalnya itu kita bisa gunakan kita menggunakan penyemprotan lidokain dari membran krikotiroid ya, itu bisa dipakai atau sebelum fiber optik masuk kita bisa semprotkan dari atas. Jadi ya just a choice ya. Seperti yang tadi saya menggunakan choice-nya kayak semprot aja langsung ketika sebelum memasukkan pipe-nya di sana. Tetapi kalau untuk sedasinya supaya pasien lebih nyaman, kita tambahkan dexmedetomidine. Oke, jadi panjang jawabannya Dr. Sindri. Oke, thank you very much.
Terima kasih banyak Dok, sangat jelas ya. Kita lanjut to Dr. Anuraju. There's a question about how could we measure the exact BMI in pregnancy obese patient, and how to exclude the total weight gain, and also about the estimate blood loss. How should we monitor, and also how could we estimate the exact weight gain and also the estimated blood loss during surgery?
Yeah, it's a very good question. BMI, from our point of view, we usually measure as a booking BMI. That's what we do. But the exact weight gain in pregnancy is still like, in a patient with a high BMI. Normally in a normal patient, we know how much weight gain they might have to gain. So they have a set weight gain, about 10 to 12 kilos that they gain. But in a patient who is obese, may or may not gain weight, and they don't consider it as a marker of fetal growth in obesity. So more sort of things they're concerned about in obesity is they look at ultrasound and fetal growth from an ultrasound monitoring. That's what they do. So weight gain per se is not taken as a consideration for in morbidly obese patients. So as long as the fetal growth scans are fine, they should be all right. With blood volume estimation, is it? Yeah, blood loss estimation is just the same as, like, you look at the ideal body weight of the patient and look at total, like how much, look at how much volume they have, blood volume they have. And measurements, as we just go by normal measurements, like, if you have a cesarean section, we weigh the packs. You look at the estimated blood loss. If they have blood lost in like trace, we measure it. We weigh the packs. We look at how much clots they have. We weigh the clots, and also look at how much blood they have in the suction, and estimate it then. And looking at the ideal body weight, we calculate the patient's blood loss and take it from there.
Thank you very much. I think it answers the questions pretty well. Yeah.
Just
Okay.
the other thing, just to remember, if there's a cervical tear or something like that at cesarean section, you mightn't see it until it's dripping on the floor. So, blood loss measuring is, like Arne said, is measuring is important, but also not just looking at the monitor, but actually looking at the patient.
Clinical estimation.
Clinical estimation as well as volume estimation, but there is that potential to conceal bleeding that's under the drapes.
Drapes and gauzes, yeah.
Yeah, but it's actually between the legs, and then
between the legs.
yeah, between the legs, and then under the drapes, and then you take the drapes off at the end, and then there's a leiter.
Okay.
Clinical estimation is paramount.
Under pads, the one is put below the patients. Or on the operating table, something like that.
Yeah. You won't find it until you take the drapes off.
Yeah, correct.
So the patient may be quite tachycardic and you don't see any bleeding. So there is you need to have a high index of suspicion that the patient is bleeding, and then treat it, because everything's happening under the drapes.
And also, just to emphasise what Arne was saying, these are young patients, so they maintain their blood pressure and their pulse till it's quite low. And sometimes with bleeding, especially, say if they had a hematoma in their vulva, there may be some sympathetic stimulation or even pressing down further down in the pelvis. So there may be a relative bradycardia. So they don't get they may not always get the tachycardia until it's too late.
Dr. Cahya, mau menambahkan? Kontrol perdarahan mungkin? Oke, baik. Ada pertanyaan lagi terkait tentang maternal obesity dan pelepasan oksitosin, dan mungkin juga for milk ejection reflex and breastfeeding. Maybe Dr. Cahya barangkali untuk pasien SC obes, hubungannya dengan oksitosin release, dan juga kira-kira ntar untuk breastfeeding gimana?
Terima kasih, Sin. Jadi kalau saya yang terakhir kita memakai ludus oksitosin, kita lihat respon. Ya, kalau belajar dari fisiologi ibu hamil, sebenarnya oksitosin kan baru, atau memang ada hormonalnya secara umum ada di ibu. Tapi ini kan sintetis yang kita masukkan dari luar untuk tujuannya untuk kontraksi uterus. Tapi sebenarnya di badannya kan sudah ada. Ya, jadi saya alirannya menggunakan dosis yang rendah. Serendah mungkin tapi kontraksi efektif. Saya kira itu karena kontraksi yang dosis yang besar, kontraksi yang kuat, terlalu kuat, terus di drip continuous post op, pasiennya nyeri, mengganggu, tidak membuat pasien tidak nyaman. Itu sih.
Mungkin Dr. Satrio mungkin mau menambahkan? Setuju. Oke, baik. Ada special question ya, ada pertanyaan spesial. Dr. Maha Alit ada di belakang, mungkin mau bertanya, Dok?
Okay, thank you. My question for Dr. Anuraju, but I think actually it's not a question, it's a, I need your opinion, Dr. Anuraju, regarding to the intrathecal medicine. You say that one of the best analgesia is intrathecal morphine, right? But here in Indonesia, our morphine is not free preservative, and as we know that every kind of medicine we give to intrathecal should be free preservative. So we need your opinion about our morphine here in Indonesia, which is not a free preservative. Thank you.
Can you ask a pharmacy to make one?
I already asked for 10 years ago, and they said they cannot.
we have. I know it's just a system problem. That's a very good point you raised. You don't, since I thought about intrathecal morphine, if you don't have has to be preservative-free intrathecal morphine. So it's a very good point that Dr. Alit made. Has to be preservative free. Don't try to dilute your morphine which is going. It can cause, the preservative can cause neurolysis, and the patient can have neurological problem later on. So sorry, I just thanks for bringing it up. What we are talking about, preservative free morphine. I guess we are very lucky. We get manufactured intrathecal morphine. It comes in 500 microgram per ml vial. So preservative free morphine. I guess.
Yeah.
From my point of view, you need to ask the pharmacy what the problem is. It's not an expensive drug.
Yeah, I know.
It's a cheap drug.
Yeah, I know.
or you might be able to import it from the compounder in Australia. So the compounding pharmacy that makes it. So the company that makes it.
I can send you the details of the company, but there can be, because it's a controlled drug, there can be implication of bringing it into Australia. But you can correspond with them. We can send you the details of the company that makes intrathecal morphine, and look at there can be ways, like it can be transferred from.
Maybe I can tell you here in Indonesia.
I guess it'll be much more. I think if you talk to the company that makes morphine, they might be able to tell you, you can tell them the evidence and say this is what it's used worldwide, morphine. Oh, you have hydromorphone?
Hydromorphone, no.
No. Yeah, in the UK they use hydromorphone. In Australia and the US they use intrathecal morphine. Isn't it? UK they use hydromorphone. So those are the two main long-acting opioids, lipophobic opioids that are helpful in pain relief. So it's worthwhile exploring. Just tell approach the company who makes morphine if your pharmacy is not doing, and brings it to your hospital, and ask them is there a possibility to get 500 mics per mil of preservative-free morphine.
Okay. So because
it's being used more, like 10 years ago, it's now being used more, I think.
Sorry? Sorry?
It's being used more frequently now, the intrathecal morphine. So the evidence, like Arnie was saying, I can understand why the pharmacy might have said no 10 years ago, but now there's more evidence.
Yeah. Now, actually, I can tell you now the position here in Indonesia right now is that many anesthesiologists here use that morphine which is not preservative free now in Indonesia. I used to use that morphine category, but since I know what was the concern, since 10 years ago I never used that morphine category now, and that's what happened here in Indonesia and in Bali also. A lot of anesthesiologists use that kind of morphine without free preservative, which is with preservative, and that's the position in Indonesia. It's still pro and con here now in Indonesia.
And the thing is, it's very simple, very easy to use. So I will tell you what we do with our spinal anesthetic, with our cesarean analgesia regime is we start with, you get bupivacaine, 0.5% bupivacaine for 2.5 mils, 15 mics of fentanyl, 50 to 150 mics of intrathecal morphine. Most of the time we end up putting about 100 mics of intrathecal morphine in most patients. And then that's it. And then they get regular Panadol, regular paracetamol, regular diclofenac. So they get a shot of paracoxibin drop or per-rectal diclofenac. And they get regular Panadol, regular diclofenac. For the first 24 hours, they just Panadol and diclofenac is enough for them. And after 24 hours, they get regular Panadol, regular diclofenac. And we have oxycodone. Do you guys have oxycodone here?
Not anymore.
Not anymore, is it? So we get about, and that too, we give very small doses of oxycodone, 2.5 to 5 milligrams of oxycodone is what we give for pain relief. And that seems to be working really, really well.
Okay. Thank you.
Thank you, terima kasih Dr. Ali. Thank you, Dr. Anuraju. We still have 2 questions left. The first one related with patient safety, because obese pregnant patient is always related with patient safety. Could you please give comments on how could we ensure patient safety while still optimizing the dose for obese pregnant patients? Please, maybe Dr. Kim first and Dr. Anu. Memastikan keselamatan pasien dengan dosis yang tepat.
The other thing that we've implemented about 10 years ago was the observations. So having fairly strict observations on all the patients who've had a caesarean section, particularly in relation to sedation scores and respiratory rate. So I think part of it is, the observations on the ward to minimise complications. So what was the other bit? Sorry, just go over the question again.
Patient safety. And also how could we as anaesthetists optimize drug selection and dosing also for patient safety?
Yeah, exactly. So I think what Anu was also saying was that regime of regular simple analgesics, paracetamol, non-steroidals, actually then make it a lot safer. They're not having as much opioid to get the respiratory depression, and also, or tramadol. So I think that's really probably the main thing. Drug selection. Basically, I give the same sort of drugs, although I probably use, now when I do a general anaesthetic, I swap over and use Tiva to minimise, and that I think that they also wake up better with that than they might from a volatile.
Okay, Tiva. Okay, any specific monitor? Entitled or something?
Yeah, so if I'm using Tiva, then I would use a BIS because
Okay, BIS.
So I would use BIS to minimise the chances of awareness, because we would have used saxamethonium initially for intubation. So there's some muscle relaxation on board, initially anyway. So then I'd use BIS as well to titrate, and making sure that would actually help with making sure that the patient's in a weight better at the end.
Okay, Dr. Anuraju, any comments?
Yeah, I'll go with what Kim said. I think we usually use the same type of regime: low dose opioids more frequently, and multimodal analgesia regime. Like you give Panadol, diclofenac, and tramadol if need be. So that gives much more of a multimodal analgesic regime in these patients. And if you have suspicion of obstructive sleep apnea, these patients invariably go to high dependency units, so they get closely monitored with regards to like they get one-on-one nursing rather than one nurse looking after about 4 or 5 patients. So that sort of adds to the patient safety in the initial 24-48 hours. They usually get looked after in the high dependency unit. They're quite morbidly obese and they have obstructive sleep apnea symptoms. So we ask them to bring their sleep if they have OSA, they'll have a CPAP. Most of them will have a CPAP machine. So we ask them to bring their CPAP machine when they come to the hospital, so they can use their own CPAP. Otherwise in a hospital they have obstruction and they don't have to. So we always tell them at the pre-anesthetic checkup, bring your CPAP machine with you so they don't get obstruction during. Because
I wouldn't have any experience in Dexmedetomidine.
Dexmedetomidine, yeah.
Yeah, I wouldn't have any experience in
Oh,
using
okay.
it.
Dr. Gus Krishna is the expert on it.
Because we've got the oxycodone. So what we do is maybe because we've got the other drugs. Do you know what I mean? So using ketamine or post-operatively, there's never a need. Because it's different. So I get it.
Okay, now last but not least, the final questions goes to Dr. Kim. In morbid obese patient, when we cannot find the landmark at all, no vertebrae, so what should we do?
Yeah, I think the other I think brain, yeah. But I think we probably have to practice using ultrasound. I'm a bit of a dinosaur because I grew up before ultrasound.
Yeah.
But I think we, as people are getting more obese, we have to practice using ultrasound to be able to use it to locate the level and the space. So I'm sort of thinking, even when we do an elective caesarean, we should actually start using that as an opportunity so that we are competent and could do it easier when we need to. And of course the other thing is, if you do have a clinic where you're seeing them more obese patients, or even when you see them on the ward or pre-op before, get the ultrasound and just put it on and see where you think it might be. So there are two things. Practice. I know we're always time poor, but think when there are learning and teaching opportunities, probably just go, okay, we're really going to do it. It's really important. Because you would have done that already when you're doing I was really impressed, you're doing that already. So then think about those difficult ones. That's what I reckon you should do. Just think about ultrasound. But if you've never done it before, then it's difficult.
I think it's with the ultrasound, practice on normal patients.
Yeah.
Like even if you have an ultrasound readily available, just practice on normal patients, because in obese patients can be quite tricky.
Yeah.
The deeper you go, the clarity becomes less and less. So unless and until you practice in normal patients, so if you have an ultrasound readily available in your department. Yeah, so just take your ultrasound and just practice with if you're doing a cesarean section. It just takes you 20 seconds. You put a probe on the back and look at what structures they are. So if you practice in a normal patients, once you have an obese patient, you become a bit more of a expert than putting it for the first time.
And then if you do it, you'll become the expert in your department.
Correct. Mungkin tips bahasa Indonesia mungkin Dr. Cah yang sering barbar anestesia. Kalau kita nggak ketemu vertebra gimana? Dr. Gus mungkin ini udah biasa.
Pakai indera keenam. Jadi kita harus safety ya. Jadi kalau bicara safety, ultrasound yang vertebra yang tidak ketemu, guideline gold standarnya harus ultrasound. Ya, kalau tidak, ya kalau memang tidak ada, obes kirim ke fasilitas yang lebih lengkap. Alasannya teknik atau patient safety. Jadi pasien bisa dirujuk ke fasilitas yang lebih lengkap. Intinya patient safety yang pertama. Saya kira itu sih.
Dr. Satrio mungkin ada komen terakhir. Dan Dr. Gus Krishna untuk menutup. Oh oke, ya. Nggak. Oh oke, ya. Silakan kasih komen, Dr. Satrio. Ya, santai aja. Kira-kira ada komennya, Dok?
Untuk itu ya, sambil nunggu Dokter Anu ya. Jadi kalau teman-teman ini ketemu pasien big kayak gitu ya, yang pertama ya memang jawabannya yang paling ilmiah adalah pakai itu ultrasound, dan nanti diliatin gambarnya sama Dokter Anu, dan sangat-sangat membantu. Saya beberapa kali juga melakukan hal yang sama. Jadi kita ini, tapi ada pakai plaster itu juga membantu ya. Jadi ininya apa namanya, fatnya itu kita coba untuk tekan sedalam mungkin gitu ya. Jadi kan ada fat, ditekan sedalam mungkin baru kita melakukan spinal di sana. Gitu, itu yang bisa dilakukan untuk very obese ya. Kemudian lines, kita lihat linesnya. Dan yang terakhir adalah intuisi. It's very important, intuisi. Banyak orang menganggap remeh intuisi, but it's very important. Percaya sama saya. Do it, and do it. You will get that intuitions. Oke, thank you.
Dr. Satrio, nah makanya kita belajar spiritual ya Dok ya. Intuisinya biar jalan.
Ya, saya setuju dengan semua dari pembicara. Yang paling penting patient safety, itu paling penting udah. Kalau memang merasa nggak mampu, kirim aja. Saya juga udah pernah pengalaman itu udah pakai USG dan ini, tapi memang jarumnya aja benar-benar udah nggak nyampe. Itu juga udah pernah saya. Jadi dan waktu itu kita belum punya needle panjang. Sini ada needle panjang. Ada ya. Nah, kalau ada needle panjang enak, bisa. Nah, dan itu nggak semua center apa tempat ada gitu, rumah sakit ada. Jadi kalau memang kalian nggak punya, mending dirujuk aja. Itu aja dari saya. Terima kasih.
Sudah bisa dipajang dulu biar bisa dijelasin. Oh, sorry for troubleshooting. We're trying to fix that for the last picture before we wrap all this thing. While we're waiting for this, masih ada pertanyaan dari floor? Is there any questions? Yang masih bingung? Pertanyaannya banyak teknis ya. Mungkin nanti kalau yang spesifik dasar-dasar fisiologi mungkin bisa kita sama-sama baca. Ada lagi mungkin yang dari floor mau bertanya? Mungkin seniornya, residennya. Oke. Baik, jadi bisa disimpulkan ini pertemuan sangat bermanfaat dan kayaknya semua udah dapat insight ya, input ya. Oke. Sekarang kita coba buka dari Dr. Anuraju.
So with the ultrasound, I think it's, if you have an ultrasound freely available, you can just try this at when you have an next patient doing a spinal anesthetic. It won't take too long. It just takes you just need to look at what you find, and just need to have two views is what you're looking for. So first you put the probe in a paramedian plane, like looking at the longitudinal paramedian plane. So what you're looking there is, when you look at this, you get a sacrum as a straight line, and then you get a lamina, So you're seeing in between here this is the ligamentum flavum, and this is a spinal canal, and this is the posterior longitudinal ligamentum flavum complex. So sacrum as a straight line, all right? So you get a sacrum as a straight line, and then you get ligamentum flavum, then a lamina, the ligamentum flavum, lamina. So you count the spaces from below upward. So you get a sacrum straight line, then you get that L5, S1 is L4, L5. So this is what you're looking for, and in an artist impression, it looks like a sawtooth. All right? So you can look at that. This is sawtooth, isn't it? So you can see it's saw. So this is the lamina, this is the ligamentum flavum, this is the lamina, this is the ligamentum flavum, this is the lamina, this is the ligamentum flavum. So this is how you count upwards, all right? Sacrum, L5, S1, L4, L5. So this is a simple view that you would get. You put it and you'll see the sawtooth straight away, and you can count the spaces from below. But as I said, if the patient is quite obese, this view would be a little bit dim, like you need to find out what you're looking for in there. So once you find the level, so in obese patients it's quite difficult to find, you don't know what the spaces are, so you look for the sacrum and then count the spaces up and say, and when you find the right space, you turn the probe immediately. All right? So turn the probe like that. So when you find the right space at that level, you turn the probe immediately. So when you are on the spinous process, you'll have a nice, like what do you call, a nice shadow like that. All right, you got the spinous process, and you have a shadow of the spinous process. And you can see, and you need to keep this sort of thing in the midline. All right, so that you're absolutely sure that's in the midline, that doesn't move. So once you keep that in the midline, you go in between the spinous process. All right, so just like how you do a spine anesthetic, you feel the spine, and then you go in underneath that. So just slide the probe very gently, and once you slide the probe very gently, you would get a view like this. All right, you try to get a view like this. This is called an equal sign. All right, so this is the ligamentum flavum. So you can see this is the articular processes. These are the transverse processes. This is the ligamentum flavum, and this is what you see as a spinal canal, and this is your vertebral body. All right, this is your vertebral body, but this is a posterior longitudinal ligament. So look for a sign like this. It's always difficult, sometimes difficult to get it. But in an artist impression, this, just like a sawtooth, what you're looking for is a flying bat. All right? You can see that. The ears of, you can see a bat here now, isn't it? This is the ear of the bat. This is the forehead of the bat. This is the nose of the bat. And this is the wing of the bat. So this is what you're looking for. It's a flying bat sign. So in that case, you're in the midline. These are articular processes. These are the articular processes. This is the transverse processes. This is the forehead of the bat, is your ligamentum flavum, and this is your spinal canal. So when you get this view, you freeze the screen, and you drop a caliper from here to here. You'd know how deep is your this thing. It's very, very easy to do. Once you start doing it, you'll find out. If you have it easily available. Try to do with a curvilinear probe, because that's what gives you much more of a depth. So two views. One is a paramedium view to count the level from up, then turn it around, find the midline, and then you go underneath, and then try to see. You need to have some sort of a jiggling, just like how you insert a spinal needle, have to go up and down. All right.
Thank you very much, Dr. Anuraju. So that's a wrap. We finished our discussion and also our last session for today. Thank you very much for Dr. Kim Osborne. Thank you, Dr. Anuraju, Dr. Cahya Aryasa, Dr. Satrio, and Dr. Ide Bagus Krishna for a very detailed presentations, very high quality imaging, and also this would obviously will enhance our knowledge in the future. Terima kasih banyak. Kita sekarang masuk ke acara penyerahan kenang-kenangan. It's like a memento from us. It's just like a special gift from Bali Anesthesia residents, registrars from Bali to you. I would like to ask the speakers, Dr. Anuraju, Dr. Kim Osborne to step forward, and also Dr. Satrio bisa maju ke depan, Dok. Kepada Dr. Cahya Aryasa sebagai panitia lokal dari BCCM Bali Combined Clinical Meeting didampingi Dr. Ide Bagus Krishna Jaya Sutawan, dimohonkan kesediaannya untuk memberikan sedikit kenang-kenangan. Yuk, oh ya, oke, siap. Jangan lupa difoto ngambilnya. Ya, yang pertama untuk Dr. Satrio. Terima kasih, Dok. Terima kasih banyak. Jangan kapok main ke Bali, main sering-sering. Oke. Tepuk tangan, give a big applause. The second one is for Dr. Kim Osborne. Thank you very much. It's a good statue. It's the symbol of virtue, knowledge, and also Balinese style dance. Yes. And the last but not least, the star of today, Dr. Anu Raju, thank you very much. Yeah. Looking similar as ever, yeah. It's like a foster brother from another father. It's very nice, yeah. Okay, we'll take a picture together first. Jangan lupa maju. Foto-foto. Picture together with the speakers first. Ya, gantian.
To all of the participants, please step forward to take some pictures.